That's why I defend the defenseless. I defend soy. I used to have to defend fat, but I don't have to do that anymore. And now I have to defend carbs, but only whole carbs, non-processed carbs. And I have to defend estradiol, estrogen in that form, and real progesterone, because these hormones, starting with the Women's Initiative, it just took us down the worst possible road of misunderstanding, and then I call it mistreatment of women. So they're not getting informed consent. Every woman can decide, I don't want to have hormones. It's an individual choice. But how can you make an intelligent choice if you don't even have the foundational information on which to base it? And that's what they're not getting.
Now, I would love for you to share with the listeners, did you always know that you wanted to be an OB-GYN? Was that the trajectory of your, young adulthood, that was the direction you anticipated going in? Or was this just a random occurrence? Because it looks like your entire career has really been devoted to the care of women. And so I know it'll be an invaluable conversation. And for listeners to know, this is the first of 2 episodes. Dr. Gersh has very graciously agreed to come back because there is so much to discuss that we could not do it in one 1-hour segment.
Well, no, actually, it was not like I was born knowing my destiny or anything like that. But I did come from a family that gave a very limited menu of career opportunities. And I never questioned it, as it turns out. And so growing up, it was always understood that I would go into a career. My mom was an attorney, so was my dad. And we just had a lot of expectations that women are going to do whatever they want to do. But I only had 3 choices that I understood. One was to be a lawyer, like my parents. Another was to be a teacher. And the third was to be a doctor. So, I get the lawyer, doctor, teacher. Which one am I best at? Well, I said, well, I'm good in science, and everything was supposed to be serving people and helping. And so I picked doctoring. And so I didn't want to just exclusively learn about science. I really had interest in like many things. So in college, I actually majored in history and dabbled in history across the whole history of mankind and did a lot of art history. So, but then I had to take all the prerequisites, of course. So I had all these other science courses that I had on the side. And then I got into medical school, and my periods went away, and they for 2 years. And when I spoke to these really hotshot, well-renowned, hundreds and hundreds of published articles on PubMed and everything else, all they told me was, you're not trying to get pregnant, so just go on birth control pills. Just go on birth control pills. And, it's but something is wrong with me. And that was really the spark that set me on my journey, is okay, like so many people, we always make jokes about psychiatrists, but we won't go there, it's either something in our family, something in ourselves that triggers us to learn more, to want to understand. So trying to figure out what was wrong with me made me want to go into women's health. And then when I did my rotation in medical school in OB-GYN, and I was doing the labor and delivery rotation, and I was delivering babies, and I saw how sick many of these women, this was a county hospital, and they were very sick. And I saw how much medicine you needed to know, and how much, I said, you know what? And also the I became an adrenaline rush addict. I didn't realize that was in me, but just the life and death scenarios that presented themselves in a labor and delivery scenario. And I wanted to do that. I said, you have to know everything. To do obstetrics properly, you need to know about medicine, you need to know surgery, and you have all of this, like when you see ER, because, you've been in that, where you have truly immediate life and death situations where you can save lives 2 at a time. And but also what I liked about OB-GYN was the continuum of care, because you not only just did like a surgeon or a trauma surgeon where you just had that one intervention and then next. No, you could create lifelong relationships with the women, because they would come to you. And that was the time when it was sort of being debated. Are women going to go to an OB-GYN just for pelvic care, or is the woman going to use the OB-GYN as their primary care physician? And I took that position because I loved medicine and learning how to deal with a lot of things. So I wanted to do more than just pelvic stuff. And I also saw the context, that everything is linked to everything, that when women have, before it was even discussed, because I go way back, that the menstrual cycle meant something to the woman's health status. It wasn't just, oh, well, I guess you can't get pregnant easily. No, it meant she's not healthy when she has a menstrual cycle dysfunction. So I guess I saw everything in that field, and that's where I am today. And then I've made many twists and turns since I began, as we all evolve, and led me to wanting to be with you here today to really help educate women about what it means to be and what it takes to be a healthy woman.
Yeah, well, and I'm so very grateful that you had that trajectory of your career and has gotten you to where you are today. I think there are a couple things. First of all, as a former ER nurse in inner city Baltimore, we were terrified of pregnant women. We did everything we could to immediately get them to the OB floor because we were terrified of women at that life stage. Number two, because we never liked having women deliver in ER bathrooms, and that happened quite a bit. Yeah. We would say, no one goes to the bathroom. If you're a pregnant woman, you're not allowed to go to the bathroom. You have to be with a healthcare professional in the bathroom. Number two, how many women listening, including myself, experienced menstrual cycle irregularities and were prescribed the pill? I remember being 16 years old. Exactly. I was 16 years old. I probably had very mild PCOS, which we're going to talk about today. I didn't fit the typical phenotype of someone with PCOS, but my cycles were so irregular. And my GYN very kindly said, we have something that can fix this problem. And I then remained on oral contraceptives until I got married. And I thought in my brain, even as a nurse practitioner, didn't even think about what the net impact was. But when we talk about oral contraceptives, oftentimes masking those menstrual irregularities, it is a huge issue. In fact, I feel like with good intent, they are prescribed. And I always say, listen, there's no judgment. When women are looking for reliable contraception, that oftentimes can be a viable option, but we don't realize what the net impact is. It's masking whatever that irregularity is. And so, you are a recognized expert on PCOS, so polycystic ovarian syndrome. And when I was reading your book, which is my favorite book about PCOS to recommend, PCOS SOS is that book. One of the things in there that I found really startling is that you mentioned that PCOS is the most common female endocrine disorder. And I thought to myself, gosh, in my mind, I'm thinking diabetes. That's usually what I think about. But and diabetes and insulin resistance and PCOS all kind of go together. Right. But that was such a profound sentence that I read. I thought I have to really take that in. So, from your perspective, in terms of looking at PCOS as a disorder, and it's a disorder related to menstrual irregularities, but it's so much more than that. Like, as I dove into your book, which I mentioned I reread last week, it really reminded me why it's so important to have these conversations, because PCOS is not benign. And and I think many of us think of it as being this benign entity, and it really isn't.
No, and it's really interesting how just in the last few weeks, several articles have been published that have been out there on, things that those of us in the medical field see all the time, like MedPage and Medscape, and they kind of they're always putting out some of the newest articles. They're like, oh, PCOS in pregnancy is associated with heart failure, more heart dysfunction, or women with PCOS are more likely to have hypertension when they get older. Of course. This is duh. There's so many things that they discovered. It's like, excuse me, we actually knew this before. You didn't discover it. And PCOS is about everything involving female health, because, and we were chatting about this before, the menstrual cycle, and you alluded to this just a few moments ago, is really a vital sign of female health status. Just like, you go into the ER and you say, what's the blood pressure? Oh no, it's like 60/30. That's a big problem, or it's, 180/120. That's another big problem. So, it's a vital sign. And instead of recognizing that when it's all messed up, it's irregular, it's incredibly heavy, it's prolonged, it's terribly painful, or you get horrible PMS, that is a giant red flag that this female's body is in trouble. Something is wrong. And it's all smoke and mirrors when you give oral contraceptives, because, and it drives me crazy. I'm sure you too. When the doctor, like you said, well-meaning, says, this is going to regulate your cycles. You're not regulating, you're covering up. So you're taking the ovaries offline, you're completely shutting them down and replacing the human, beautiful, natural hormones and rhythms, which, you deal with, fasting, intermittent fasting. So we know that it's not just what you do, it's when you do it. And like, it's not just that you have some kind of hormones, it's when they come out in pulses and the rhythms and the beautiful lunar cycle. And there's even circadian cycles of hormones. None of that happens when you're on a birth control pill. So you're changing the entire physiologic dynamic of the female. And of course, there are repercussions. They're just not, immediate in most cases, occasionally, and they're always sort of subtle. They're like long-term, like when people are exposed to endocrine disruptors, chemicals in our world, they don't fall over dead. Like if you have a lot of chemicals that are inappropriate, that's everybody has a lot, but like BPA, which has the most research in PCOS, that's why I brought that up. It's a ubiquitous, it's everywhere endocrine disruptor. It doesn't just kill you immediately, but it can have all kinds of profound long-term effects. And that's what we're looking at. We live in a world where we can only associate causal relationships when they happen like immediately. But no, there are causal relationships that can happen even decades. For example, they have now found out that young women back in the day when DDT was sprayed all over for mosquito control, like on beaches, and they would just go around and spray DDT, and young girls like 12, 13 years old were literally sprayed with DDT. Those women have substantially increased risk of developing breast cancer in their 40s. And we wonder, why are all these young women suddenly, why do we have a 7-fold increase in premenopausal breast cancer? It's because of chemicals that they may have been exposed to many years earlier. We know that in utero exposure to various toxic chemicals can increase childhood leukemia. So, and that could be years later. So the bottom line is that birth control pills, and we could talk forever on that. Maybe someday we'll do another just on, what it means to have contraceptives, all the different types out there, because it's really a huge, important deal that every woman know about. But birth control pills are not human hormones. They don't regulate anything. They take down your own hormones. They don't fix you, and they have a pro-inflammatory propensity. And that's really important for women with PCOS to know. Women with PCOS live in bodies that are metabolically unhealthy. They're not just reproductively challenged, they are truly metabolically unhealthy. So if you say, well, what the heck is metabolism anyway? When you say you're there, people throw the word metabolism around all the time. So what are you talking about? So metabolism is the creation, utilization, storage of energy. So what's the difference between you and a person who isn't alive? Well, you make energy. I mean, that's why, everyone has seen TV shows where they have the EKG, right? And you see the heartbeat, and then, it's flatlining. That means the heart is no longer creating energy. That's an electrical signal. The same thing with the brain. Flatlining. That means you have brain death. The brain is not creating energy. So you need energy in order to function. And like old people, they're sitting on a bench in a park. Is that because they love benches? No, it's because they don't have the energy. They would love to be running around like the kids out there on the field, but they're tired. They don't have the ability to make that kind of energy. So metabolism is like a critical thing. And women with PCOS have an altered, not healthy metabolism. They don't make energy well. And that's for every organ system in their body, because estrogen is critical for the creation of energy. And it has many, many functions, but that's a huge one, because we have these little energy factories in every cell called mitochondria. And they create the energy by burning our energy source, AKA food, glucose and fatty acids, which turn like into ketones and so on. But in order for that to happen, you have to have proper estrogen in the form of estradiol, the estrogen made by the ovary. That is not what is in a birth control pill. And when you don't have proper estrogen, you also don't have proper functioning of your immune system, because estrogen holds the key to immune function, which is critical for survival and very involved in reproduction, because we don't want to kill with our immune cells our little fetus, right? And we don't want to kill the sperm. It's like an amazing thing. And estrogen regulates the immune system. Now, that means it works the switch that turns on and turns off inflammation response based on what the body needs. Like if you have an infection like COVID, you want instantly the inflammatory process to be turned on, but then you want resolution, which some people don't get, right? They get the cytokine storm. Well, estrogen, which by the way, there have now been reports, finally, I knew this from the get-go, that women who have proper estrogen are going to do better. That's why women statistically do better, among other reasons. But so the bottom line is that when you have proper estrogen, the immune system is regulated, you make proper energy, so all the organs work properly, and then it goes on, which we can touch on a lot of these other things. But when you don't have the estrogen, like when women with PCOS, and you have immune cell dysfunction, you are going to be in a pro-inflammatory state, because by default, you go into that inflammatory state. So you are more prone to blood clots. And birth control pills, most people have heard of this. Birth control pills increase blood clots. Now, why is that? Is that an isolated fact that birth control pills have this single effect on platelets that create blood clotting? No, it's because they initiate a low-level state of inflammation by decreasing the production of nitric oxide, an anti-inflammatory antioxidant gas that is required to maintain proper immune function in a whole different set of ways. And also it sort of activates the immune cells, the innate immune cells, like the attack cells, to be in a pro-inflammatory state, because birth control pills have only one effect on one estrogen receptor, whereas estrogen from the ovary has a balanced effect. So you sort of get stuck in that pro-inflammatory state. Well, now it's additive. And there are published studies to show this, that when you take birth control pills and you have PCOS, you are even more pro-inflammatory, and it increases even more the risk of blood clots. So we know that we don't give birth control pills to women who have uncontrolled high blood pressure. We don't give them to women who just had a heart attack. Like, if they're so great, why don't we say everyone has a heart attack, let's give you birth control pills? Of course, that never happens. So we know that there are women who've had blood clots. We don't give them birth control pills. So to me, women with PCOS should be in that category of high risk, like women who are elderly. We don't give women who are smokers. I mean, there's so many of these, don't give kind of categories for birth control pills. And to me, women with PCOS actually fit into that group. So it's really important. I know there's a lot of time on birth control pills, but it's important because that's the mainstay treatment of PCOS. Like for you, for me, like, because I'm like you, I'm like the smaller percentage of PCOS women who were not the 80% who are overweight and substantially obese. But don't underestimate the seriousness of the so-called lean PCOS, because they can suffer and develop all the same complications. They just have a little bit of advantage of not carrying as much adipose tissue, but they have a lot of disadvantages too, because they often have poor body composition and lower muscle mass. So don't think that they're so great off. They have a lot of potential risk, especially as they get older into the menopause years, of having a lot of cardiovascular problems and other problems. So PCOS is important for every woman to understand, even if she doesn't have PCOS. But like you said, it's such a prevalent condition, and there's no one actually keeping records. No one is actually out there trying to collect data. So the only data we actually have is from insurance billing data. that's really, we have the data, and a lot of times doctors code it wrong. So, they'll put down a symptom, or they've had so many published reports about women go to like 11 doctors before they even make the diagnosis, which is kind of weird because it's kind of obvious in most cases, I think. But the bottom line is that we don't know the exact incidence, but we know it's at least 10% of all reproductive aged women. That's a lot. And it may be at least 25% have there. It's a spectrum, because it's a syndrome. So that's why there's different severities, somewhat different manifestations, and so on. But every one of you listening either has PCOS or knows someone with PCOS. And the information that goes into treating PCOS properly, the lifestyle part, which is the key part really, is really relevant to everyone, because it's really foundational lifestyle medicine. And women with PCOS just have a more severity status of everything that we talk about, but everyone has toxins in them. Everyone has to live with circadian rhythm challenges. Everyone has to live with dietary challenges, stress challenges, sleep challenges. So everyone, regardless of whether you have a full-blown diagnosis of PCOS, have some degree of challenges that all women with PCOS have, like on steroids. So it's good to really understand all of this.
Well, and I think it's really relevant because how many of us weren't diagnosed with PCOS until we tried to get pregnant? And for myself, I had a really excellent GYN and I was temping. I was doing all the right things. I was temping and I kept bringing in my charts and I said, I think I have a luteal phase defect, and we can describe what that is. Because it was evident that, I probably had low progesterone. Anyway, a whole bunch of things.
Of course.
And so my GYN very appropriately said, we need to refer you to reproductive endocrinology. Went to see the reproductive endocrinologist. He confirmed that I indeed likely had this thin phenotype of PCOS. I ended up doing Clomid and IUI to get pregnant with both my children. And for me, it was very humbling because I had assumed I was very healthy. And all of a sudden I'm looking at my husband and I and thinking, like, if we're really healthy and we're having trouble getting pregnant, and the more I talk to patients and friends, I realize there's a whole generation of us that are struggling with infertility. And for many people, they're told it's male factor. They're told, they don't understand why they're infertile. For many of us, it was because of the PCOS piece. And once that was addressed, then I was able to ovulate and get pregnant. But I think it's important for people just to understand that the leading cause of infertility is undiagnosed or diagnosed PCOS. And
Absolutely.
so it is a huge issue. And my hope is that through this podcast that we can help, build awareness. I know you're doing wonderful work in this area as well. So what are some of the common symptoms? Some of the ones in your book were the traditionals. And then there were a couple that were surprising. And I'll give an example to listeners. I had been told for years, I had great teeth, but I was told there was my gums, very inflamed gums. I had gingivitis. I even got referred to a periodontist. And thankfully the periodontist put the brakes on and said, listen, I think it's because you're on oral contraceptives. I think when you stop oral contraceptives, your gums will get better. And sure enough, they did. But gingivitis, just inflammation of the gums, can be a sign of PCOS. But what are some of the more common ones that people may recognize?
Well, I'm just going to backtrack for 1 second, just for people out there who are like, what the heck is PCOS anyway? So just in terms of like manifestations, because we're talking about symptoms, because a lot of what PCOS is diagnosed based on symptoms. So, you get a committee of doctors, they get together and they define what is the name of the condition, and that's another battle that's ongoing. What are the criteria for getting that label? So to get the label of you have PCOS, you need, according to this committee, I don't totally agree. They were outliers like me and many others, the Androgen Excess PCOS Society, who disagreed, that you need two of the following three, though, officially. You need to have irregular cycles of any kind of irregularity to any degree. You need to have elevated androgens. So androgens are like the male type hormones, but women have them just in much smaller amounts. And that includes testosterone, and that is produced by both the adrenal and the ovaries, 50-50 in a normal reproductive age woman from each of those organs, and DHEAS, which comes only from the adrenal. and or manifestations like, you have to shave every day, which is unfortunate and common. And now they've included recalcitrant cystic acne, like on the hormonal acne on the jawline, that type of thing. And androgenic alopecia, so it's like the female version of male pattern baldness. And the last criteria is PCOS ovaries on ultrasound. And I want to just mention that in a young teen that's within, say, of just 5 years of onset of their menarche, their first period, this is not a useful diagnostic tool, because part of becoming reproductive and maturing is having what look like PCOS type ovaries. You can call it like the ovaries are still on their training wheels and they can look like that. So you don't want to overdiagnose, and that's another issue. Like the young teenage years is a little harder because, as you know, 90%, well, now you know, 90% of teens have acne, which is a whole other topic because of gut dysbiosis and inflammation and diet and lifestyle and everything. But since 90% of girls have acne, and young girls will have PCOS ovaries, even if they're not going to develop PCOS, you got to be careful about the diagnosis in that age group, and you have to do other things. So we won't talk about the very young teens right now, but just be careful about not doing those kinds of things and making those judgments on those girls, like a 14-year-old. So, but you could say PCOS tendency, something like that. So those are like the criteria, and you need 2 of 3. Now, once you understand that PCOS is by its foundational nature a woman functioning in a deficient state, an insufficient state of estradiol, the estrogen from the ovary, and then you understand that estradiol has a role, I call it the gluing together reproductive functions and all metabolic functions. Every organ system in the body has estrogen receptors, and there's different estrogen receptors, and they have a predominance of one type or another in different organs. That's why you need estradiol, the one that has the balanced effect on the different estrogen receptors. And in medicine, they're trying to create what they call designer estrogens that work on only one of the receptors, but you're naturally then creating an imbalance to try to get an effect, and you're always going to end up in trouble, if possible, unless you're short-term treating some specific condition, like we'll say breast cancer. Okay, we're not going to, that's a whole unique situation where everything is altered. But if you're just treating to have a healthy body in a woman, then you don't want to try to treat only one estrogen receptor. But recognizing that there are these tremendous complexities of different estrogen receptors, different amounts in different organs, but every organ has an involvement, a huge involvement with estrogen and hormones, which estrogen is a hormone, and estrogens are a family of hormones, and estradiol is the estrogen made by the ovary. That we have different interactions between the receptors. They can up and down regulate each other. There are even receptors in different organs like the heart that work with estrogen as a cofactor. We call them estrogen related receptors, where estrogen isn't even what's binding to the receptor, but it needs to be there, sort of like a coenzyme, in order for that receptor to bind properly with what it is supposed to bind with and then create. We even have receptors, especially in the brain and the heart, that bind to certain specific estrogen metabolites that are made when estrogen goes through the liver and gets transformed, what we call biotransformation. That's how unbelievable estrogen is. We even have a specific gut microbiome dedicated to dealing with estrogen called the estrobolome. I mean, I cannot underestimate the critical importance that estrogen plays in the female body. And women with PCOS have ovaries, and this is 80% of women with PCOS. There's also a version that's predominantly adrenal, which has similar manifestations, but a somewhat different etiology. Let's talk about the mainstream, which I focus on in the book, which is at least 80 to 85% of all PCOS women fit into the ovarian etiology. And they don't make enough estradiol. And now we know that due to exposures of the fetus in utero to endocrine disruptors like BPA, that's what's had the most research, bisphenol A, which is everywhere. It's what's in hard plastics, can liners, cash register receipts, a lot of dental appliances and so on. And it actually is a huge endocrine disruptor in a multitude of ways. And it can actually alter the way the endocrine system develops in terms of the receptors, so that you have receptors that don't work properly. So it doesn't matter if you have a hormone, but if it can't work on the receptor, you're not going to get the desired effect. So basically, the thing to remember is that women with PCOS have a problem with the production of estrogen in the form of estradiol from their ovaries. The receptors are not working optimally. And so basically, they have an insufficient amount of estrogen in the form of estradiol working throughout their body, and every organ system of the body needs it. So basically, all the microbiomes. So we have now this incredible new understanding that we are just one part of who we are, that we have these collections of trillions of microbes that live everywhere. And the biggest collection is the gut microbiome, but we have other microbiomes, vaginal, skin, I mean, every organ system. I was taught incorrectly, I bet you were too, even, though you were taught later, that everything in the body was sterile. I mean, like, just the thought of that, like, I don't know why I believed it at the time. I know I question everything, but like, is there a stop sign at the cervix that says bacteria do not enter? I mean, they enter. I mean, how else do you get PID? Like gonorrhea and chlamydia infection, they can go up. Okay, so you have microbiomes of the placenta, the uterus, the tubes, the ovaries, the brain, everything has, different degrees of bacteria, different types, and so does the mouth, the oral cavity. So getting back to your gingivitis, which, by the way, I also, I'm like you, and I also had gingivitis, and I kept wondering, what is happening? Why do my gums bleed? I mean, like, I'm doing everything right. It's because the mouth microbiome, it turns out that estrogen is key to maintaining the microbiomes of everything. That's one of the reasons why women with PCOS can get this recalcitrant cystic acne and they've shown this, the microbiome of the skin is different. It doesn't have the protective, what we call the commensals, that actually, there's a war going on everywhere in your body where the good guys with the bacteria, the microbes, are fighting off the bad guys. And when we don't have enough good guys, guess who wins? The bad guys. And then we have colonization with pathogenic bacteria that actually create harm. And that's true for women with PCOS, unfortunately, because estrogen works with the immune system, as I've mentioned, and it works with creating the proper secretion of sebum, and in the vagina, glycogen, which is the food source. It's like a starch that the vaginal lining cells make to feed the good lactobacillus, which keeps the vagina in an acid state. So you don't have overgrowth of Gardnerella and these other anaerobes, and then you have the BV and you have the yeast infections, and you don't have the right bacteria to help you fight off these things. So that happens in the mouth as well. And they have now a few studies. I'm so happy when anyone does any studies on PCOS, because it's really talk about insufficiencies. We have tremendous research insufficiencies with PCOS, even though it's, like you said, it's like the most common endocrine disorder of reproductive women, and it's so minimally researched and funded. But we now have data that shows that, it's another of course, because every microbiome is altered, the microbiome of the mouth. And so you have the good guys in the mouth, the commensals, the helpful bacteria that are fighting off the bad bacteria. There are not enough of them. So the bad bacteria take over, and then they start creating inflammation. And inflammation causes, of course, whenever you hear itis, that means inflammation, like appendicitis, arthritis, gingivitis. It means that you have inflammation in your mouth, in your gums, and that's because you don't have the right mouth microbiome. And there's research now. I recommend a probiotic toothpaste, and it's not enough research, but there is some data to support like probiotics for a lot of different things, but it's in its infancy, but helping to get the right microbiome established. And that means don't use poisonous stuff in your mouth on a regular basis, which is a problem because, back in the day, they had certain types of mouthwashes that they used as their little saying, like kills germs on contact. Well, that's a problem because not all of those so-called germs are bad dudes. A lot of them are the good dudes. So like antibiotics, you're not just killing bad ones, you're killing good ones. And that's another thing that, of course, happens a lot, is a lot of antibiotic use. And so we have problems in many people with gingivitis, but women with PCOS, like, that's why I say it's like everyone else, only worse. Okay, so, they just have the worst case scenarios of so many different things, like women with PCOS. And the first research came out of China that they have gut dysbiosis. They have the wrong microbiome of their gut, which results in impaired gut barrier known as leaky gut, which then the toxins that are produced by the wrong microbes in the gut leak out between the cells of the lining of the gut into the body proper, where 70+% of all the immune cells of the body reside. And those immune cells of women with PCOS have a lower threshold to creating inflammation. This actually was published out of research in the University of Indiana back in 1998, that, and a friend of mine who was a researcher, one of the few in PCOS, found that women with PCOS, their immune cells take less to create a very big inflammatory response, like putting out all those inflammatory cytokines. So you have like the worst of all worlds. You have the impaired gut barrier, the leaky gut, the endotoxemia, the toxins coming in, and immune cells that have a lower threshold to creating more substantial inflammation. And so, there you have it. It's like a perpetuation. So you have multifactorial things happening in women with PCOS, creating this chronic state of low-grade inflammation, which drives problems in their vascular system, in their heart, in their brain, in their joints. That's why the multitude of symptoms, and that's why women sometimes with PCOS will have more of a dominant something, like gingivitis, or they can have palpitations, they can have mood disorders, which are so much more prevalent, anxiety and depression and ADHD, because the brain has inflammation and lowered energy production. I mean, that's like the worst of all worlds. And so we need to help. And now they have the new articles I mentioned that women who are pregnant with PCOS are more prone to developing like heart failure. Well, that's like another, for me, a big duh, because it's so fascinating. Women have different hearts than men. This is not even recognized by cardiologists because of pregnancy. Pregnancy changes everything. So when a woman is pregnant, what happens to her blood volume? It doubles. So that means her heart has to pump twice as much blood around. That means that heart has to do double duty work. So what is unique about a female heart versus a male heart is the number of mitochondria. The capability of creating energy in a female heart has to be dramatically higher than in a male heart. Well, as I told you at the beginning, what is critical to the creation of energy? It's estrogen working in the mitochondria at all different levels, both through the creation, through what they call the electron transport chain, and also working with a very important enzyme called superoxide dismutase, because when you have the creation of energy, you create byproducts that are toxic, and those have to be eliminated. And one of those is called superoxide. It's two oxygens together, poison as can be, but it cannot get out of the mitochondria. It's stuck in the mitochondria. So if you can't do something to get rid of it, to change it into something less toxic, then it's going to kill that mitochondria. And that will happen if you have a deficiency of estrogen, because estrogen works to keep the enzyme that works to take that toxic superoxide and converts it into hydrogen peroxide. Now you think, well, it's hydrogen peroxide, that's poison too. But hydrogen peroxide can diffuse out of the mitochondria. And then there are other enzyme systems that are also involved that convert it to harmless water. So you have to have estrogen so you don't have the killing off of the mitochondria, that they work properly. Well, women with PCOS don't have proper functioning of the receptors and so on. So they're going to have problems with creating energy in their heart during pregnancy, where there is a double energy need. The heart has to pump twice the amount of blood around the body. So it can fail. And in fact, women, when they have energy deficient hearts on echocardiogram, it shows up in a very unique way called mild diastolic dysfunction, which is an energy deficient heart that's stiffer and it doesn't relax properly. And you know what the cardiologists typically do when they see it? They say, oh, that's typical. I mean, like women, we see that all the time in women. It's like, you know, excuse me, that shows that's a sign. It's like the menstrual cycle is messed up, and the solution is, well, just give them birth control pills. We see that all the time. It's a problem, guys, doctors out there. It's a problem when you have an energy deficient heart, when you have menstrual cycle irregularities, and the cardiologists don't recognize it. So like at least somebody now is bringing that up and they're publishing it. I mean, of course I knew that. Of course, anyone who understands estrogen and PCOS is going to like expect that to be the case, because if you can't make energy in the heart, what's it going to do? It's not going to do very well. And that's another thing. Women with PCOS get tricked into getting pregnant. In a way, you got tricked. By the way, I was on Clomid. I got tricked, but no one prepared me. No one did I don't know if anyone did anything with you to try to help us be healthier before they tricked our body into ovulating. And that's what happens in women with PCOS and also when they do IVF. But women who do IVF, because they're not getting, they're infertility patients with PCOS, they have the highest failure rate of anyone. And why is that? Well, because their ovaries are very inflamed. You don't have inflammation in one or two organs, it's in every organ, even in the ovary. They've done studies where they take follicular fluid out from around the egg, and guess what they find? It's permeated with inflammatory cells. So they have ovarian inflammation. By the way, low progesterone is related to inflammation. Inflammation will drop the production of progesterone. And so that's a sign. When you have low progesterone, you have luteal phase defect, you have inflammation. Like, work on the body. Don't just trick the body into getting pregnant, because we're so clever. Because once you trick the body into getting pregnant, women with PCOS have the highest rates of pregnancy-related complications, miscarriages, everything that can go wrong, it goes wrong in higher amounts. Gestational diabetes, hypertension, preeclampsia, abruptions, both babies that are too large because they get too much sugar because of the gestational diabetes, and babies that are growth restricted because of placental dysfunction, because of vascular problems. Because in the end, you can think of PCOS as a vascular problem because the arteries are inflamed and that creates damage to the artery. And estrogen regulates the entire system that controls how the blood vessels constrict and relax, called the renin-angiotensin-aldosterone system. Almost no cardiologists. I just had an article published in December. You can Google it on PubMed, go to PubMed or Google Scholar, and it was published, and it was a featured article. I was so happy about that in Mayo Clinic Proceedings this past December of 21. And it talks about estrogen and the renin-angiotensin-aldosterone system, which is critical for immune function, which relates to vascular function. And they're all intertwined because part of the inflammatory response is constriction of arteries to maintain blood pressure so you don't go into shock from sepsis or blood loss. But the cardiologists and internists, they just think it's just women get old and their blood pressure goes up, or women with PCOS have hypertension, and they're not thinking of the mechanism, that it's because estrogen is not properly functioning with this. This is a whole system of enzymes, the renin-angiotensin-aldosterone system, which we call the RAS. It's a whole system of enzymes that are located throughout every organ system in the body and in the blood. And it's so critical to regulating immune response for survival, so that you don't go into shock and so on. But when you're in a chronic pro-inflammatory state, you're going to have pro-inflammatory constriction of blood vessels, and that happens in pregnancy, and then they have vascular problems and they end up with placental problems, and then you have poor nutrients and blood flow to the placenta and then to the baby. So you have babies that are growth restricted because they're not getting proper oxygen and nutrients. So you can have all these kinds of problems, preterm deliveries. So my goodness, we have to get women healthy before they get pregnant, and not just trick them in fertility centers into getting pregnant and then celebrate and walk away. And also, when you have an unhealthy female, and this is so sad, their babies are in an environment that's unhealthy, and they are more prone to having gene modifications that we call epigenetic modification, and they are born already metabolically dysfunctional. So they're more prone to having things like hypertension and obesity and mental, like emotional problems, ADHD. So you've got to have, even, I hate to say this, but this has been published, autism is higher in women who are unhealthy when they're pregnant with PCOS. So every woman out there who is interested in getting pregnant, whether you have PCOS or not, take time we call it preconceptual counseling. You have to be optimally healthy before you conceive, not just to lower your own risk, to improve your fertility, to lower your risk of pregnancy-related complications, but for the whole life of your child. And metformin isn't the solution. So I just have to do a call out here against metformin, because metformin is used rampantly in women with PCOS. It's actually officially an endocrine disruptor. It can alter hormone functioning in the body, just what women with PCOS need. It's also a nutrient depleter. It depletes the body of B12. But in terms of pregnancy, they did studies to look at it because they wanted to give it to women who are pregnant to help them to prevent gestational diabetes. Well, it's still given like rampantly, but the study showed it didn't do that. It didn't do any of the things they hoped it would do, like lower the incidence of preterm, slightly, like a few days, preterm delivery in some women. That was the only benefit, but it didn't lower preeclampsia, didn't lower hypertension, it didn't lower gestational diabetes, it didn't do like stillbirth, it didn't do any of those things. All it did was like a few days, had women who they had fewer women deliver like at 37 weeks compared to 38, but it was a very small number, very, very small. And who knows what that really even meant, but none of the things they were looking for happened. But when they looked and followed the babies who became little toddlers and little kids, by age 4, the children who were in an environment in utero that the mom was getting metformin, by age 4, those children were more metabolically unhealthy than matched women with PCOS. So they matched them according to all the criteria who weren't on metformin in terms of their metabolic health. They had more visceral fat, they had more glucose, insensitivity to insulin problems. So they had more insulin resistance. So they were actually metabolically more unhealthy at age 4 than the kids who were not exposed to metformin in utero. So that is not the solution, guys, not the solution. And in terms of understanding PCOS, you can see how it can really link to every woman out there, like lower your exposure to plastics and chemicals and pesticides as much as humanly possible. Eat a healthy diet. And by the way, in terms of preconceptual counseling, and this is actually spelled out a lot in my second PCOS book, the Fertility Fast Track book, I incorporate a lot of nutrition, lifestyle, and fasting to help women to really reduce inflammation, help their gut microbiome transform, help to restore gut integrity. And fasting, has a lot of those wonderful benefits in the right population, of course. And so there is, it always comes across as hopeless. I never want to end up sounding like, oh my God, you are cursed women out there, you have PCOS, because the first step is to define the problem. We have to be honest. If we don't define the problem, how are we ever going to solve it? That means being blatantly honest, even when it hurts, to really understand, like, okay, you can look at Earth, okay, Earth, you're in a bit of trouble now, with, pollution and, weather problems and everything. So you got to define the problem even when it hurts. And that's true for women with PCOS. We have to just spell it out. But then once you define the problem, then you can come up with really efficacious, true solutions, not just whitewashing, like you have a wall full of termites and I don't really want to deal with that. So I'm going to just put wallpaper, nice, pretty wallpaper on that wall. But you know what? The termites are in that wall. And when you put birth control pills into a woman, she is actually more inflamed. She has lowered production of this really critical antioxidant, immune regulating gas called nitric oxide. and she has more gut dysbiosis. That's actually been shown. And there's one little study, because nobody cares enough to do more studies, that showed more circadian rhythm dysfunction, like your altered timing in your brain and your master clock that helps keep all your organs working in the same time zone. Like you really don't want your pancreas working in central time, your stomach in Eastern time, and your liver in Pacific time. But that's what's happening in women's bodies with PCOS. So we don't want that. So we definitely want to look at all the different things that are really going on. But then we have solutions. I mean, that is so important that we define the problem. It looks grim. Okay, but there's so much hope. There's so much we can do, but none of it is a birth control pill, and none of it is metformin, and none of it is going to happen like spontaneous combustion. So that means everyone has to work really hard. This is a labor really of love for yourself, for your future children, for everybody who loves you, that you're going to do the work to actually get healthy. And you know what, if you and I mean, I had to discover I had PCOS because nobody was helping me. And, I used fertility drugs for my first, and then, it's like, okay, I get it, and then I evolved, and then I had more kids spontaneously. And, my first, and I had 2 kids that were over 9 pounds. My biggest baby was 9'6". That's a clue. I'm not big. And how did I have a monster baby, 9'6"? Clearly I had a glucose regulation problem, and then now, my daughters, my kids have to, it goes to the next generation. So, we tell them, okay, you have to eat healthy, guys, you have a risk right here for yourself. That's why, by the way, for PCOS, 50% plus will have a first-degree relative who also has PCOS. And even the moms of PCOS women who say they didn't have PCOS, they have a 60% higher risk of developing diabetes in their life because there's something still going on in them that is, probable. So they have a higher risk of diabetes, even if they didn't have PCOS, because they probably have some of the PCOS genes. So nothing is so simple. There is a genetic propensity that we are activating and worsening, sort of like all the worst genes or the best genes, but we're turning them on their head. So we're turning something that was okay and minor and insignificant or even beneficial in ancient times into something pathological today. But we can turn it back around on its head, and we can, come out on top, all you PCOS gals out there. Don't think it's hopeless.
No, and I think for listeners to understand, this is one of many reasons that I wanted you to come on, because you're just such a breadth of experience in sharing the research and sharing clinical applications. And every single question I had written down, you answered without me even prompting you. But one thing I want to reemphasize, it wasn't until I struggled with infertility that I went to my mom and my aunts, and sure enough, they probably all had mild PCOS. They all had used Clomid. I mean, and I kept saying, why aren't we talking about this? And so I think it's important to make sure that you're having those conversations with your moms and your grandmothers and finding out if people have struggled with any of these issues. Now, I want to be respectful of your time, and we are going to have a second episode talking about perimenopause and menopause, but I'd love to kind of end talking about supplements and other ways that we can address PCOS. You've alluded to, we have a shared love for intermittent fasting. And I know you talk about, prolonged fasting, but, to me, one of the things that was really interesting when I was doing research for our conversation is that for PCOS women, as you mentioned, they have the circadian dysregulation. So they are already at a disadvantage that they are not going to have high quality sleep. So one of the first things that you talk about in your book, is light exposure, sleep quality. What are some of the other things along with some supplements? Because there are some special ones in here, and I'm glad that you address metformin, because I get that question a lot. But things like myo-inositol that are so helpful for PCOS women.
Absolutely. So in terms of lifestyle, it's really all the fundamental lifestyle issues, but really taken to their ultimate level, because women with PCOS have the ultimate metabolic challenges here. So in terms of sleep, absolutely, you need to do sleep hygiene. which means getting away from all those blue light screens. And really, as longer is better. So preferably a couple of hours, it'd be really good. Watching the sunset, the colors of the sunset actually help to lower cortisol, which women with PCOS tend to have high cortisol at night and low in the morning, a flip, because they have a flip circadian rhythm. And the reason for that is that estrogen works the master clock that helps to set all the timing for the different organ system. So women with PCOS do live as if they're in a jet lag situation, which is associated with actually all the metabolic and symptomatic things that women with PCOS. So all of you women out there who work night shifts, you actually have a lot of the same challenges. So keep that in mind, and see if, like if you're nurses or police officers or whatever, you can get seniority fast and do whatever to try to get on the day shift. But women with PCOS do have this. So we want to help them to sleep because they do have a lot of sleep problems. And sleep is not the absence of awake. Sleep is when you have gigantic blood flow to your brain, it cleans house, you have changes in hormones that are very dramatic. And you have like all kinds of changes in your cardiovascular system, your blood pressure should drop. You actually make growth hormone, which helps to build lean body mass, which you don't have enough of when you have PCOS, like muscle, which is like the most important fat burning organ structure and glucose burning structure in your body is muscle mass. So sleep is definitely essential to health in a myriad of ways. And women with PCOS have a lot of also altered sleep breathing problems, sleep apnea. So I get a sleep study on all of my patients because estrogen works in the brain. There are receptors all over, including the centers that deal with breathing at night. So, and of course, some women are also obese, so they tend to have obstructive sleep apnea from their tongue and so on. But even so, there's central sleep apnea, which has to do with the breathing mechanisms that are triggered through the autonomic nervous system. They're part of the nervous system that controls things we don't think about, like breathing and heart rate and blood vessel, status and so on. So sleep is critical. So you want to go to bed preferably by around 10 o'clock. You want to get that surge of melatonin at 2 a.m. You want to avoid all the blue lights for a couple hours. And there's so much you can do besides watching screens. You can listen to wonderful podcasts. Just don't do the video. You can do books on tape. You can play board games. You can actually write. You can clean your house. You can do the laundry. You can talk to your partner. I mean, you can do a bunch of stuff. So you can actually listen to television if you just, put a giant towel over the screen, because I have listened to many television shows while I'm cooking and I don't see a darn thing and you can kind of follow what's going on. So you just sort of turn your TV into a radio, it's fine. So there's plenty you can come up with, guys, that besides like watching computer screens and television and so on. So, and your iPhone needs to go into like, turn it upside down mode, so you're not looking at it. So that's so critical to get adequate sleep. And in terms of supplements, a little bit of melatonin is the way to go. For most people, it's best to start with small amounts, like 0.5 milligram a couple of hours before, to welcome sleep rather than using melatonin as a drug. Now, sometimes I do that short term, but in young women, they should have the capability of making melatonin, which changes when you're 80. But so basically try to use small doses. 0.5 milligram will often be a place to start a couple of hours before you go to bed. And sometimes, some of these herbals like ashwagandha, lemon balm, L-theanine, which comes from green tea, passion flower, these can be very nice. And they're blends, and you can do it in teas, you can do it in capsules and so on. So some of the calmatives can be very helpful. And of course, mind-body medicine, which is essential. So I love guided imagery. You can learn meditation, there's progressive relaxation, there's tapping. So there's a variety of forms of mind-body medicine. I love body work, like who doesn't love a relaxation massage? But maybe a spouse, you can get lovely essential oils that can also be very calming, and so forth. So that's great for sleep. In terms of light, that is so important. At night, I sleep with a sleep mask, or else you get like blackout blinds. You got to be in a very dark, cool room to have. I have a fan blowing on me. That's wonderful. Like it's like, woo, sometimes it's chilly. I'll pull up the blanket. That's good, than being like sweating and hot. really not going to be great for sleep. And in the morning, bright light will help to set your master clock, to keep it from, the word that we use is drifting, literally drifting. So you can get bright light by like opening all the windows and the blinds, or you can get a light simulator kind of a thing, like a light box, and put it at 10,000 lux for 30 minutes every morning. Try to get midday sun, and try to get outside without sunglasses for at least 15, 20 minutes. And if you wear contacts that are tinted, try to get out without them, because you're trying to get light to go into the receptors that are actually in the retina of your eye that go directly to your master clock to help set it. So light therapy is really important. And then nutrition, of course, you need to have all the those magical polyphenols, I call them the special sauce, a plant-based diet. I recommend going vegan for a few months, because when you have the wrong gut microbes, they actually metabolize animal protein to create toxins like TMAO. And so it's best to have either minimal, like no more than 3 ounces, or just go on a vegan diet for a few months, not forever, but really you want to nurture your gut microbiome. And they love plants, they love fiber, all kinds of fiber. And you want to make sure that you eat across the colors of the rainbow for all the different types of nutrients and the polyphenols. There's actually a dance with the magical polyphenols. And what's interesting is that many polyphenols, and people don't recognize them, they're actually phytoestrogens, that they don't even get it, that people know isoflavones that come from legumes, not just soy, but all the beans and lentils all have isoflavones in them. Not just soy, okay, if you don't like soy for whatever reason. Organic soy, unless you have an allergy to it, is actually a fertility food because it's an isoflavone. It actually binds to estrogen receptors, the beta. That's the type that's predominantly in the gut to help restore gut health. But other things like the skin of red grapes have resveratrol, which resveratrol is a polyphenol, and it's a phytoestrogen. And from like pomegranate, it can turn down the road into urolithin A, which is also a phytoestrogen. Nuts and seeds have phytoestrogens. Seeds, often like people talk about flax seeds, they have lignans. Lignans are phytoestrogen. So a lot of the magic that comes from polyphenols are actually because they're phytoestrogens, and they help, they're like magic. They bind to estrogen receptors, but they're not estrogen. And they have all kinds of amazing beneficial effects. They can even go into the circulation and bind to estrogen receptors elsewhere and create all of these benefits that are amazing. So many, many fruits, vegetables, legumes, beans, nuts, seeds, all have this magical property of being phytoestrogens, along with having wonderful fiber and all the antioxidants, the minerals, and so on, because you need all the right nutrients, macro and micro, to run the machinery of your cells. Like if you don't have enough B12, you're a goner. I'm just telling you, you gotta have it all. So that's why I do recommend a good prenatal vitamin, because then you can't take 200 supplements. That's like a little over the top, but like a really high quality prenatal vitamin will at least have all the basics. Get it with methylated Bs in case you have an MTHFR, which is another topic, in case you have a genetic issue that you don't do this magical process called methylation. Well, you can have pre-methylated folate, pre-methylated B12, that for most people is going to serve you well. So that would be great. And then fitness, exercise. The ultimate best is interval training, high intensity interval, but you can't start with that. We don't want injuries, because you're more likely to have weaker joints and inflammation in your joints. So, I really recommend working with a personal trainer who knows what they're doing, because you got to look at what was their training. Look for someone who's certified by the American College of Sports Medicine, not by a gym, okay? American College of Sports Medicine, that's like the epitome of organizations that trains personal trainers, and they know what they're doing, because I don't want anyone to have an injury. But work your way up gradually. But any movement is better than no movement. And so sedentary lifestyle is the worst. You know, they came up a few years ago with sitting is the new smoking. You know, it's like so toxic to the body to just be sitting. So, you know, by the way, they've shown that fidgeters, like I always like to tap my feet, you know, fidgeters actually good, you know, la, 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 la. You know, fidgeters actually burn a substantial number of calories that help to keep them healthier and thinner. So don't sit still, like march in place, you know, tap your feet. If people find you annoying, okay, then stop. But, you know, do it when you're in private. And yeah, don't just keep moving and find something you love, the people that will do it with you, because it's really hard to stick with something you hate. It's like I say, find recipes with all the vegetables that you love. There's so many out there. My mom, you know, she tried, but she made everything taste like a soggy mess. So I never got to feel good about vegetables, but now I love them because I learned how they can actually be cooked, you know, and that you don't get like a box of frozen mushy spinach, you know, that was the day, you know. So, but now you can get wonderful fresh stuff. And, you know, if you don't have a farmer's market, then go and buy the best organic food you can. You know, that's where you spend your money, you know, as much as you can, and be skimpy on something else, you know, but don't try to save money by buying crappy food. And so you want to also time your eating. That's the backdoor way into getting your circadian rhythm reset, is through timed eating, what we call creating synchronization of your organ systems. So I usually recommend, based on studies that actually were done for women with PCOS, that you try to put most of your food into the early part of the day and very little at the end of the day, and not eat more than 3 times a day. And that means call them 3 meals. I don't care about labels for meals, because you can eat any food at any time. There's no special breakfast, lunch, or dinner foods. They're just meals. And it's best to actually have breakfast be your biggest meal, and then have like 2/3 of your calories for breakfast, 1/3 for a very early dinner or late lunch. But most people won't do that. So you have to be realistic. Then try to either have your biggest meal breakfast, or else make it lunch, and try to have an early small dinner, and then stop eating. You have to have at least 13 hours from dinner to the next breakfast. And please don't skip breakfast, because that's when your body is most genetically aligned to digesting food, keeping your insulin down. So you can eat the same foods at night or in the morning, and you'll have a totally different insulin and glucose response. Like, it'll be much better if you eat it in the morning. That's why we say in the book, if you have to have dessert, eat it with breakfast, because your glucose will raise to a higher level at night, but much lower if you eat that same, you know, dessert in the morning, and your insulin will be more actually functional. Insulin receptors work better in the early part of the day, and they work less well. Everything is on a timer. Digestion is better, and you're more likely to get heartburn and indigestion if you eat at night. Most people figure that out, but then the solution isn't to take pharmaceuticals like they advertise on TV, you know, acid reducers and things. The secret is eat according to your body's genetic programming, which is in the early part of the day. And then, you know, I mentioned about stress and toxin exposure. So you want to try to avoid plastics, try not to, like, bring your own cups. And when you go to like a place like a Starbucks or something, and, you know, like, and have them fill it, like stainless steel or glass, tempered glass. So try not to use, and when you put on those covers, those lids, they're terrible. They're all what we call phthalates, the soft plastics, and they all get absorbed into the heat, the hot liquids, and they're poison. And for men, they've had tons of articles showing that they destroy their sperm. So their sperm counts are plummeting. So, you know, men out there, you know, you have men in your lives in some form or fashion, tell them don't do that either. And all this actually does apply to men, because we're all human beings on planet Earth. We're all earthlings with the same kind of circadian rhythm issues. So we can do, you know, all of these things. And in supplements, in a nutshell, myo-inositol is my ultimate favorite. It works in the ovary in women with PCOS to improve their egg quality, improve estrogen production, and improve ovulation. Like, what a fantastic thing that is. And there are multiple, like around 7 inositols. They're actually sugar alcohols, and they're all the same molecular formula, but they're arranged differently in space. So we call them stereoisomers. Like, here's my hand. this is still my hand. It's just in different arrangements. So those are stereoisomers of my hand. And there's a lot of talk in the PCOS world about D-chiro versus myo. So in a normal, healthy, reproductive age woman, the ratio of myo-inositol to D-chiro is 100 to 1, 100 times more myo than D-chiro. In women with PCOS, it tends to be about 12 to 1. So only 12 times as much myo as D-chiro, so not nearly enough myo. The liver uses D-chiro predominantly for glucose regulation and glucose production. But the problem is that D-chiro in the ovary actually blocks ovulation and it blocks the action because it sort of acts as a blocker. So it blocks myo-inositol. So I don't use D-chiro at all. When they sell it in the ratio like 40 to 1, that's based on data that they think is like the normal ratio in the blood. Well, that's not the ovary. And also, who says that if you swallow it, even if it really is in a 40 to 1, that it's going to get into anything in that ratio? And in the gut, there's actually data that in the gut, when you swallow it, D-chiro blocks the absorption of the myo. So like, just go, do all the lifestyle stuff and don't take the D-chiro, just take the quality myo-inositol, like 2 grams twice a day. And you can also use berberine as a replacement, sort of, for the metformin, because it also is an insulin sensitizer. It works to kill off bad gut microbiome, and it is very good for the cardiovascular system. I don't usually like to use it like indefinitely because I'm never sure if I could be doing anything to good microbes. You never know, kind of like antibiotics. But we just don't have the data. But it's an alkaloid extract from a number of different plants like Oregon grapefruit. And there's a lot of published data that is very positive on berberine. And in fact, there was some studies comparing the effect of metformin and berberine on IVF, and berberine won. Whenever they compare lifestyle and metformin, guess what? Lifestyle always wins too. So berberine is another one of a very good choice. And NAC, N-acetylcysteine, which acts as an antioxidant, and it helps with glucose transport, and it has been shown to help improve ovulation as well in women with PCOS. It's also great for menopausal women. They're not all single use, and nothing has just one effect. And then, most women with PCOS are vitamin D deficient, but you can't just pour endless amounts of vitamin D into women, because what happens is vitamin D is fat soluble. So it can get stored in fat tissue. And so the amount in the blood is going to be low when you measure it, but the total body content of vitamin D can actually be getting higher and higher. So you don't go above like 5,000 IUs a day, please. I mean, no matter what the level is, you can't just keep pushing it. It's getting in, it's just getting in the fat tissue. What we need to do is all the lifestyle stuff so that we can actually have some weight loss and deal with that problem. So don't just keep pouring endless amounts of vitamin D. Remember, it is actually stored in the body long term. So you don't just like think it's bottomless pit. Okay, don't do that. And so in terms of others that are kind of like can be very helpful, CoQ10 can be very helpful to help with the mitochondrial function. Curcumin can be very helpful because it's amazing as an anti-inflammatory. So there's just like endless. Quercetin is amazing as a polyphenol that helps to stabilize immune cells, like mast cells, so that you reduce inflammation. I always try to be aware of what I call a problem of a lot of functional naturopathic and integrative doctors. They create a problem called, I named it pillitis, too many pills. So I try to temper my enthusiasm of prescribing too many supplements and going with what's actually manageable for people, and focusing on like the most key issues for them. But those are ones that are very, very key, along with, like I said, a good prenatal vitamin, so you don't have to take a separate everything. Women who have cystic acne, then I would, definitely include more vitamin A. I mean, you have to look at the individual and what's going on with her, and I check levels. Like, I monitor and then measure and then monitor again, so definitely it should be individualized. Now, that's what I talk about, personalizing it. And because everyone is unique, it's a spectrum, it's a syndrome. And so you want to focus. And then if they have a lot of gut problems, you've got to focus on gut health, and I give DIM, and I definitely give L-glutamine. Sometimes I give now like butyrate. So, I mean, we've got to help restore the gut through both diet and some targeted supplements. So I usually start my patients with what I call a reset for a month. It's to help reset their diet if they're eating garbage, unfortunately, like the standard American diet. I try to give them, the proper foods and then a few supplements to try to restore the integrity of the gut lining cells. Those are so important. So we don't want to have perpetual gut, problems with lots of leaky gut and so on. So these are complex things, but there's so much you can do on your own. That's why the books that I write are self-help. I mean, I use pharmaceuticals sometimes. I mean, to be honest, I'm an MD, so I prescribe hormones. I mean, I have to give progesterone to induce periods. I can't let them, people risk getting uterine cancer. So if their estrogens are really low, I'll give them bioidentical estrogen, just like I would give to a menopausal woman, because you can't heal without estrogen. So if you're going to get them to make more, you sometimes have to start them off, kind of like, once again, like training wheels. And in some cases, when women are like 100 more pounds overweight, I will give them pharmaceuticals like the GLP-1 agonists, like semaglutide that's out there, but as tools and bridges to health with an end game, like an exit strategy, which is not usually present among like the endocrinologists. They start a drug with no idea of what's going to happen in 1 year, 2 years, 5 years, 10 years. Like, what's your strategy long-term? They have no strategy long-term. We always have a long-term strategy. So I look at the pharmaceuticals I use as a bridge and a support to getting health back restored. So, but I don't talk a lot about pharmaceuticals and such in my books because you can't access them yourself. So these are all like the self-help kinds of approaches, which are massive. And for many women, you don't need to go on pharmaceuticals when you do these lifestyle changes.
Dr. Gersh, on our last podcast, we really laser focused in on polycystic ovarian syndrome, and you graciously agreed to come back again and now talk about middle age and perimenopause and menopause. But I would really love to start the conversation talking about the Women's Health Initiative. As many of the listeners know, this is a study that came out in 2002, and I was just starting as a new nurse practitioner, and being in cardiology kind of safely tucked away, I didn't really have to deal with the ramifications too much, but I would imagine it probably created a significant ripple effect in your practice as a GYN.
Well, I would say more like a tsunami, definitely, because the whole paradigm of what hormones do, if they're good or bad, completely shifted when that study abruptly ended. I mean, it didn't end as planned. It ended because they felt right then and there that more harm was being incurred than benefit, and they just stopped the study. And it really created a huge, like 20-year ramification of harm. It's been like so devastating to women's health. And it really completely created a mass of misunderstanding about what hormones are and what they do and what menopause is even all about in the woman's body. And so I'm really happy to have this opportunity because the Women's Health Initiative was like so many things. It was begun with the best of intentions. It was actually believed at that point when it was being created, which took a long time. It was a hugely expensive study funded by the National Institutes of Health. And it was designed to actually show all the benefits. That was the original thinking, the benefits that would come to women from being on hormones. But they already had an inkling, they should have had, from a previous study called the HERS study, which was to look at women who had already documented cardiovascular disease. And then they were given what was the hormone du jour, which was the conjugated equine estrogens, the brand name Premarin, combined with medroxyprogesterone acetate, which is a progestin. Progestin is a made-up word for a progesterone endocrine disruptor. meaning that it actually binds to progesterone receptors, but not with the same actual effect as if it were the human bioidentical produced progesterone. So in some cells, it could act as almost like a blocker, what we call an antagonist. In other cells, it can act as a promoter, like what we call an agonist. So it has different effects. And the drug that was used for the estrogen, the conjugated equine estrogens, are actually hormones. It's not just estrogens. It's actually combined with other stuff like different androgens and other things that are coming out in a pregnant horse's urine. And this was all they could do initially in the day. They took this urine, they dried it, and they put it into a tablet form, and then they gave it to human women. And it actually did work to suppress hot flashes and night sweats, because although it was a horse's estrogen that it was trying to get rid of, that's why they call it conjugated. It has already gone through the liver, gone through a transformational process that changed it into becoming water soluble so it could go out with the urine. So the horse was trying to get rid of it. It didn't want it anymore. And it came along with many different kinds of estrogens that would be found in a horse, but never in a human. And so just the fundamental understanding of what is estrogen is so important, because they use estrogen, they toss it around like it's all one thing. And estrogen, it's a family of hormones. So there are different estrogens. So a horse makes equine estrogens. They're different from humans. They have different molecular composition. And the human female has different forms of estrogen. The one that the ovary makes is called estradiol. Now, the placenta in pregnancy makes a different one as a dominant one. It also makes the other estradiol, but the dominant one is estriol. And then when you have conversion of androgens to estrogens in, for example, other peripheral tissues, other sites, the dominant organ that makes estrogen in menopausal women is fat or adipose tissue, because it has the enzyme that can convert androgens predominantly coming from the adrenal gland into a different estrogen called estrone. And it turns out that estrogen can bind to different types of receptors, and the different types of estrogens bind differently. And estrone, the dominant estrogen of menopausal women, binds to the alpha receptor. Estriol, the dominant one in pregnancy, binds to the beta. And then estradiol has a balance binding, and there's other receptors on the cell membranes that we call like jeepers. So it's more complex. Every time we learn, there's more complexity. And these receptors are not static, they're dynamic, they're transformational, and they interact with each other. So you have really different effects if you have one type of estrogen or another. It would be like saying you need a B vitamin. Well, which B vitamin? B vitamins are a family. Everybody knows that there's B1, B2, B12, different Bs. They're not all the same. And estrogens are, the word is tossed around. And then on top of that, when they talk about estrogens, they throw in other endocrine disruptors, chemicals that can interfere with every aspect of estrogen, its production, distribution, its degradation, its elimination, its receptor binding, and they throw that all in with estrogens. So and these are healthcare professionals at the top of their game, like from major universities like Harvard, and they're tossing these terms around like they're all the same. And then, so here's my analogy, which sounds crazy, but it really applies to the Women's Health Initiative. So they did this study with these different chemicals that are never found in a human body. The estrogen product, the conjugated equine estrogen, was given orally, which means it gets even transformed through the digestion and the liver, so that when it enters the bloodstream, it enters with all these horse estrogens, plus the other is predominantly turned into estrone, which works on the binder, the receptor, which is called alpha. So it's not the same as having estradiol. So you do a study with strawberry flavored jelly beans, and you find, lo and behold, it increases cavities and diabetes and obesity. So what's the conclusion? Never eat an organic strawberry. I mean, like talk about you're making this incredible conclusion that has nothing to do with what you studied. And that's what they did. But in the paper itself, it said these conclusions only apply to what was studied. But that isn't how it was spoken about, even by the people involved in the study. They suddenly applied it across the board to every dose, every form, every type of estrogen. And then remember, what they used was medroxyprogesterone acetate, which turned out to be really bad, really bad for women. And that was actually underlying most of the bad outcome, was actually not even from this other crazy stuff, the Premarin, but actually from the medroxyprogesterone acetate. And so the bottom line is that none of this that I just said was understood, or I mean, we did know, but it wasn't conveyed to anyone anywhere. And so the general message came out: don't prescribe hormones, don't prescribe them. And it was like sort of a dogma: don't prescribe them. But if you must, because they do work best for night sweats and hot flashes, they couldn't get off, get out of that one. So if you have to prescribe it, then you give at the very tiniest possible dose to try to suppress the symptoms for the very shortest period of time. And this dogma, which is erroneous, simply has stuck. And 20 years later, despite all the scientific data we have, it just, I'm working so hard to undo this like totally wrong mindset about hormones. And that when you study something that is not human, that has other effects, that are actually technically endocrine disruptors, like, I always say, like, if I gave you a little plastic cup and I put it in some kind of special kind of modified Vitamix, and it turned it into powder. So now I have a plastic cup that has been powderized, okay? And then I put it in a capsule and I said, here, take your hormone every day. This is it. You would say, that's my hormone. But that's really an analogy, because the plastic is actually an endocrine disruptor, a xenoestrogen. It can interfere with estrogen in all sorts of ways. Well, so too is the conjugated equine estrogens. And it's same thing for the progestin. It's not progesterone. And this I've read articles that are published in major prestigious journals, and they use the word progesterone when they're referring to this chemical man-made progestin. And like they're the same, and they're not the same. It's the same strawberry flavored jelly beans versus organic strawberries. And it's created massive confusion and fear. So, I'm just here to set this story right, just get it right. Let's talk about what really is the science of hormones, what really is menopause, and what it really does to a woman's organ systems in terms of everything, her metabolic status. And metabolism, which is tossed around that word a lot, is really the spark of life, the creation, distribution, storage, utilization of energy, which is so critical because you want to eat to provide energy, but you don't want to overeat, you don't want to undereat. We have systems in the body in play to actually make everything just right, but now they've been so mucked around with, people don't know if they're hungry, they're not hungry, they eat, they're so dysregulated, all the rhythms of the body. And much of this is controlled through estradiol, the estrogen made by the ovaries, which some very smart people, and it wasn't me, came up with how to create an exact replica, and a complete clone, completely indistinguishable from estradiol made by the ovaries. And we now, which we didn't have that way back years ago, but now we have that. So why are we not utilizing that and recognizing menopause for what it is? Natural, universal, and not healthful. And those all are not synonymous, that, everything that's natural isn't beneficial. Like, oh, how about tornadoes and hurricanes and fires and tsunamis, So there are natural things, we won't go into climate change, but there are natural things that have always happened that are not beneficial. And we need to look at death, well, death is probably good for the planet as a whole, because just think there'd be no room for anyone new, but for the individual, not so great. So aging is inevitable, but not so great for the individual. And I look at aging not as how many years you've lived, but on how many deficiencies you've acquired. And when you don't have hormones, you are definitely going to get major additional deficiencies, because every organ system, including the gastrointestinal system, whereby you digest and absorb vital nutrients, macronutrients, micronutrients, is not going to function optimally. And that sets the stage for cellular dysfunction, immune dysfunction, and chronic inflammation, and all the diseases that we consider chronic diseases of aging. And all of these can be delayed. I'm not saying, you can never get old and you can't have conditions, but all of these things can be really dramatically delayed when you incorporate hormones alongside of all the other essential lifestyle types of procedures and styles and living and all the things that you have to do, because it's not one thing. It's the total package of how you live your life. But you can't be healthy optimally if you don't have the right amount, the right rhythms of these essential ingredients. I call them the life hormones, not sex hormones, life hormones, our estradiol and our progesterone.
Well, I think you did such a beautiful job explaining not only the Women's Health Initiative, but the differentiators between synthetic hormones versus bioidentical hormones. I was coming of age as a new nurse practitioner in the early 2000s, and I watched my mom and all of her sisters stop all of their hormones. And I am now looking at my aunts, all of whom I'm very close to and love. And I'm starting to see some of the side effects for those that have not been on bioidentical replacement of hormones, the cognitive changes, bone health issues, heart health issues. And I really think that perhaps my generation, as we are kind of evolving into menopause, as you mentioned, it's a natural process to no longer have periods of fertility, but with greater awareness. And I think many of us are looking at this from a point of empowerment, that we now know way more than perhaps we did 20 years ago, but we're starting to see the impact of women and providers. And I say all the time, there's a whole generation of providers and a whole generation of women who are fearful of hormones, and it shouldn't be that way.
Oh my goodness, I see it every day. Like yesterday, I had patients come in and their doctor said, no way can you be on hormones. You can't be on hormones. They're bad for you. And it's like, oh my gosh, like back to the drawing board, this person doesn't understand that if you understand like a basic premise of what does a hormone do, it delivers information, vital information to the cell. So basically it can trigger the production of signaling agents. It can produce through the nucleus for nuclear receptors. It can produce vital enzymes and proteins. So but none of this will happen properly if you don't have the signal to tell the cell what to do. So it's like, the old, sort of like adage that, what are you going to do with an orchestra if you don't have a conductor? So you can have great musicians, but if the conductor never shows up and tells them what to do, they're going to be silent, or they're going to create noise, because without the conductor, they're going to be off each section, the winds and the percussionists and the strings, they're all going to be off like one measure or even a few notes. So it's going to be noise. You have to have the great coordinator of all the organ systems to work in sync in the same time zone and to do the right things so that one thing ends up in the proper sequence to the next. And that requires these vital hormones, and they interact. Like a lot of people don't know that, for example, estradiol upregulates, so it makes more functional, the receptors for thyroid hormone. So that's why every woman, when she goes into menopause, she often, a lot of them, they go to a doctor and they say, I Googled this, Dr. Google said, these are the symptoms of low thyroid. And guess what? I have all of them. I must have low thyroid. And then the tests are done and the thyroid levels are within the reference range for what always that means either, that means 95% of random people had from this value to this value, but you're in that range. So they say you're fine. And then, of course they think, oh, another woman who needs, antidepressants or something, right? Tranquilizers, like she's another mental case, and she is hypothyroid, because it doesn't matter how much hormone you have if it doesn't work properly on the receptor. We know that very well with insulin, because people talk about insulin resistance. You can have plenty of insulin, but it isn't working to get the glucose from the blood into the cell. So, and then if you have plenty of thyroid hormone, but it's not getting onto the receptor to create the desired effect in the cell, then it doesn't matter, because it's the equivalent of being hypothyroid. And so testosterone receptors are dependent on estradiol receptors, and progesterone and estradiol, they up and down regulate each other's receptors. I mean, it's a very complex and dynamic system that's going on that changes how cells work. And we're talking about other systems as well, signaling systems, like these hormones like estradiol work along with, and this is like trendy now, like peptides. A lot of people, oh, peptides, so like what tells the peptides to do anything? I mean, estradiol. And then people are talking about like these magical coenzymes and these other enzymes called the sirtuins. And there's the CERT1, 2, 3, and they're very involved in metabolism and in burning fat and rejuvenation. They're often triggered, as you well know, by fasting. Well, guess what? NAD, which is a coenzyme for the enzyme. Now, if you don't have the coenzyme, the enzyme is like mega sluggish, like it won't work. So it's like the on switch, you need to have this coenzyme that is NAD for the sirtuins. Well, guess what? They're all interrelated in a bidirectional way, by the way, the sirtuins and the estradiol, bidirectional, they work together like so many things, they're not one direction. And then you need estradiol for proper function of these enzymes. They're sirtuins, they're called histone deacetylases, which are triggered, like we said, by stressors like fasting. But you need that estradiol there. So I keep saying, a lot of the systems in the body that people are focusing on, and even the people who are advocating for these things, they don't get it, that these won't work properly if you don't have the estradiol. And then when you look at, you can learn a lot by looking at reproduction. I keep going back to that. I figured this out because I did thousands of deliveries, that the body's immune system has to make drastic changes to allow a pregnancy to occur. And all of the enzyme systems, the signaling agents, they all exist within the reproductive system, as well as like the circulatory system. People don't even know that. Like cardiologists, like you started in cardiology, they don't have any clue, for example, that the renin, angiotensin, aldosterone system is all of those agents, they're in the reproductive tract too. This is, everything's about fertility and reproduction. Sorry, guys, whether you want to have babies or not, that's how we evolved. And every system links to that, including, of course, the immune system. And pregnancy is when you have to have massive adaptations of the immune system. So if you look at like the hormones, like what happens, you've got to down-regulate the innate immune system so it doesn't attack and kill the fetus. So what calms down that system? Well, guess what? It's the progesterone is very big on acting as a calming agent. So what happens if you don't have that? And that in the brain, it actually can help to reduce neuroinflammation, as can estradiol. So everything is working in this beautiful, symbiotic, coordinated way to regulate the immune system, which ultimately is what they call aging, right? Inflammaging. And young people who have this accelerated inflammatory state of that's chronic, someone labeled it metaflammaging, metabolic issues leading to chronic states of inflammation. Well, every immune cell in the body has receptors for these vital hormones, every immune cell. And why is that? Well, of course, because you've got to regulate the immune system during pregnancy. And so what's so interesting is that low levels of estradiol are more pro-inflammatory. If you think about the menstrual cycle, you can learn so much from female reproductive system. During the menstrual cycle, estradiol levels are super low. And it's a pro-inflammatory state. You have inflammation in the uterus. You produce these pro-inflammatory agents called prostaglandins that create a little bit of cramping. It's supposed to be like a mini labor. You get a little cramping. The same system kind of in more like mega states is what happens that initiates labor. So you have a little bit of cramping because you're getting rid of this old dead lining tissue, which has to come out. But at the same time, you have to regulate the immune cells because some of this dead dying tissue is going to come out the fallopian tubes into the pelvis. And so you have to program the immune cells. And this is all done through the endocannabinoid system. And it's all done through the hormones so that you don't have an overabundance of inflammation and that the immune cells gobble up these dead dying cells that are coming out from the uterine lining. And that becomes very dysregulated in women, for example, who have endometriosis. And it's now we have triggered that, tied that back to types of endocrine disruptors for progesterone. So we learn a lot from these different conditions and so on. And so we have this sort of more inflammatory state that needs to be controlled. And if you have really massive menstrual cramps, that's a sign of too much inflammation. And that can be due to hormonal imbalances, nutrient imbalances, chronic stress, environmental toxicants, nothing simple. That's why you have to be like the medical detective. And then, when you are having a spike of estradiol that precedes ovulation, that actually becomes very anti-inflammatory because you don't want the immune cells to attack the incoming sperm or the newly created embryo. I mean, the whole thing is so interactive. And that's why understanding how hormones work in the body, then it will set the stage for understanding best ways to give hormones when our ovaries cease to make them, and understanding that reproduction being the prime directive of life, when we lose reproductive capability with menopause, we also lose the ability to regulate all the systems that are essential for reproductive success, because you have to have, for example, a very robust circulatory system. The heart has to pump way more blood because the blood volume about doubles in a pregnant woman. So the female heart is quite different, even though it looks kind of the same, than the male heart. It is much more capable of producing energy. But without estradiol, it loses that energy and it develops what's called mild diastolic dysfunction, which is sort of like a stiffening or an energy deficient heart, which can be seen on an echocardiogram and is usually ignored by the cardiologists who say, we see that all the time. Yeah, but it's a sign that the heart is suffering from lack of energy and it's stiffer. And that can lead to what's called heart failure with preserved ejection fraction. It's just like it's a different kind of a heart failure than what is called generally congestive heart failure, but it can lead into congestive heart failure. So, I mean, we need to understand the differences between male and female physiology with the immune system. Women have way more immune cells than men. Women make more antibodies. They are able to mount a bigger, robust inflammatory response to an infectious agent. Like women are better at surviving sepsis than men prior to menopause. So understanding how the female body works and why it works that way and how these hormones are essential for every system in the body will help to understand the consequences, this really cataclysmic event that is really the loss of ovarian function. And it's really important to stop even thinking of menopause as a moment in time, which is defined menopause by 12 consecutive months without a spontaneous bleed. So where'd that come from? Well, that was made up. Why is it not 13 months? Could it be 6 months? It could be whatever you make it up to be. So stop thinking of it that way. Think of menopause as a process of ovarian aging or senescence. And it starts long before that last official menstrual period, because we never know that except in hindsight, if you even let that happen. And my patients, I don't want that to happen. Why would I want them to go 12 months in a hormone severe deficiency state? What am I accomplishing? Nothing. And so we already know that vascular disease, like thickening of the lining of the arteries, inflammation, plaque development, hypertension developing, which is not an early sign of vascular disease. That's already, you got advanced state by the time you have hypertension. All of that is happening during the years preceding that last menstrual cycle, as the hormones go in this sort of crazy downward trajectory with up and down spikes. It's crazy time. That's why, it's like a crazy roller coaster. But we need to understand that if we really want to optimize female health, and then understand that when a woman gets to that stage of life, I call it her health savings account, right? So what she has done all those decades preceding menopause will set the stage for how she's going to go through menopause in terms of the degree of symptoms and also the sequela. So if you go into menopause with a great set of bones and muscles, and your brain is working well, you're not in a state of brain fog, you have a great cardiovascular system, lots of muscles. If you enter menopause in great shape, then what I say is that your engines on your plane in perimenopause, if you have a 2-engine plane, 1 engine goes out, but you're still flying, but you have 1 engine out. But when you hit full blown, no more hormones from your ovary state, testosterone is a separate thing, but no more ovulation, no more estrogen in the form of estradiol, no more progesterone, then you got 2 engines out. So at that point, depending on the health you have at that point, you either go into a nosedive, crash and burn, or your plane turns into a glider and you get to kind of sail the winds. You are ultimately going to go down and hit the earth, but you can do it gradually and smoothly. And I want to turn it into a really long journey as a glider, but you will do better, and I can do better as a doctor if you enter the menopausal transition in a state of health rather than metabolic chaos, which we know many women who are in the reproductive years are not exactly in prime health. So it's never too early, like from conception on, to try to be healthy, because we know that everything starts actually, even prior to conception, with the state of the eggs in the mother before she even gets, to get them fertilized. So, that's why I'm into big preconceptual planning and health, because you really got to plan for the future very early to get through all those menopause years and have what is everybody's goal, right? Healthy longevity, that you live to be, I just say 100, maybe you can get to 120, but I'm just being very modest here. Let's get you to 100 in great shape, that you can live a really high quality life as opposed to just existing. And you can't have that really unless you're like this 1 in a million. There's always the exception, point to the exception to the rule, someone who has genes no one's ever seen before, but in general, okay, in the vast majority of human females, you can't have optimal health and functioning without having those hormones. And it's so critical to not be afraid of them, to embrace them, to love them, and understand that your ovaries didn't go from being your friends to suddenly producing these wonderful hormones to suddenly, when they stop working, which can be anywhere really over 20 years, that you can have menopause, that from being our friends, our friendly hormones, to being our deadly hormones. Because the average age of menopause, what's called normal menopause in the US, is 45 to 55. That's a decade right there, okay? And so if a woman goes in menopause at 45 or 55, 10 years apart, her estrogen in the form of estradiol becomes evil for this woman at 45, but it's okay until this woman at 55. And then there's late menopause, which is 55 plus, and then early, which is 40 up to 45. And then, which unfortunately I fell into that group, I think, because I was up at night all the time, circadian rhythm problems with all those deliveries. And then premature menopause, which is before the age of 40. So there's quite a bit of range. So if you figure like 40 to 60, that's going to encompass the vast majority of women who go into menopause. That's 20 years. So women who have an early menopause, like I did at 43, they are supposed to be hormone deficient for, an extra decade or more than another woman. And then that we already know what happens. Women who have early onset of menopause have early onset of all the diseases of aging. Like, duh, it's not how many years you've lived, it's how many years you've lived without your hormones, So that's why I'm a huge advocate. I never stop saying menopause is natural, but that doesn't matter. Everything we do in medicine is to counter so-called natural. Like, come on, replacing joints is natural. putting in new lenses for your eyes to replace your cataracts is natural. Stents in your arteries are natural. All those pharmaceuticals are natural. I'm trying to do something that is not natural, but in a natural way, so that you don't end up with all that other unnatural bad consequence and then all the other interventions, so that you just replace what's missing that nature didn't really care about you having because you're no longer reproductive. And maybe for the planet and the species, maybe you're not so important as an individual, but we kind of say, you know, I'm not giving up my seat anytime soon, but I want to enjoy my stay, you know? So it's I mean, we're going to be here. Why are we just promoting longevity so we can keep people alive with no quality of life? I just want to be super proactive and understand what aging is really about, what hormones are about, and just say, okay, so we'll just give it. Like, how great is that? How simple is that to give hormones to recreate the hormonal environment of a young, healthy, reproductive woman in an older woman? In fact, they did this with testosterone. They gave males who were metabolically unhealthy, 65-ish males, testosterone levels to equal that of a robust, healthy 19-year-old guy. And guess what happened? They lost belly fat, they put on muscle mass, they had cognitive improvement. Oh my gosh, like hormones actually change how you feel, how your body works, like duh. Of course, if somebody took out someone's thyroid gland because they had a big benign tumor, say, this happens, nobody would say, well, that's okay, go on Prozac. That's okay, meditate more. You don't have a thyroid gland. You don't have any thyroid. Not all those other things, not Prozac, but all those other things can be beneficial, but they're not going to replace your thyroid hormone that's missing. When you don't have the estradiol and the progesterone coming from your ovaries, nothing else is going to replace them other than them, you know? So let's just give women what they lose so that they can stay the beautiful, healthy creatures that they have been, hopefully, and want to be. And if they weren't that healthy before, it's never too late, as long as you're here, to do better, you know, to help them live much better lives and start from where you are and build a better future.
Well, thank you for so much insights and advocacy for women, because I still feel like every day, I know you must get these questions. People express fear about if they start hormones, what's going to happen? Are they going to gain weight? Which unfortunately is a common concern, that there's a lot of fear mongering about hormones in general. But if you're just understanding that even at a cellular level, replacing these hormones has a huge net impact, not only on your quality of life, but the way you sleep, the way you interact with your family and your loved ones, your, personal and private relationships as well. Let's really pivot a little bit and let's talk about the changes that are occurring in perimenopause to kind of set our bodies up.
Sure.
I feel like in particular, even though I trained at a big research hospital, even though I have a lot of medical professionals in my family, nothing prepared me for perimenopause. Absolutely nothing. I don't recall ever having a conversation about it with my GYN. And when I did actually have an appointment and I was explaining to her my periods were getting very heavy, it just so coincided that my yearly annual exam, and my GYN said, "Oh my gosh, your periods are so heavy." I said, "Yes, I've been telling you this." And the options that were given to me were oral contraceptives, an IUD, an ablation, or she said, "You're in your early 40s, you're done having kids. We could just do a partial hysterectomy." And I just said, "Time out." This is not what I want to be doing. But let's kind of unpack what's starting to happen physiologically in these perimenopausal years. As you mentioned, can be a protracted amount of time, could be 10 to 15 years prior to women actually go into menopause. But it's these changes. I jokingly say, God has a sense of humor, because I have teenagers and I'm going through reverse puberty. And so I think it's important for women to really understand, like, what's changing in our bodies that's contributing to symptoms that maybe initially we don't think are a big deal, but then we realize 3 or 4 years later, like the sleep is bad, the anxiety and depression are bad, the periods are heavy, they're gaining weight. The things that they used to do to help maintain body composition and overall health are no longer working for them.
Well, honestly, perimenopause and the menopausal transition is more difficult to treat than full-blown menopause, because you still have ovarian function, but it's unpredictable. So what happens is, you have a lowered amount of eggs. You also have less healthy eggs. So they are not going to respond to the same degree from the stimulus from the brain through the pituitary, which then the pituitary makes these hormones called gonadotropins. LH, luteinizing hormone, and FSH, follicle stimulating hormone. So the brain is the great sensor of the body. So in the beginning, what's going to happen is, because you have fewer eggs and they're not as healthy, the amount of estradiol that's going to be produced, and also then ultimately progesterone, is less. And often when I do testing like menstrual mapping, I will see that even though they're still ovulating, even the ones who are still having regular cycles, the amounts of hormones is less. And then of course, as things progress, the cycles can become quite changed. Often the luteal phase, the time after ovulation until the bleeding, which is when the progesterone is produced, is not as done as well. So you have a shorter luteal phase. So you have shorter cycles in terms of, like, maybe you had 28, it goes down to even 21. And that's part of the ovarian aging process, which would, of course, as well reflect on fertility. Of course, there's a very strong correlation between ovarian aging and reduced fertility. Like every woman knows, in the early 40s, her fertility is nothing like it was in the early 20s. And this is a consequence of the quality of eggs and then relating to the production of these hormones. And this is going to change the cycles. And so women can have very different types of cycles, because the uterine lining tissue, the endometrium, grows and is transformed by these hormones. And so what can happen that can give you these crazy heavy periods, and then also some women get very sporadic periods. It's very unpredictable, even for the same woman over time. And that's why everyone is the same. It's such a unique time for each woman. But as the egg quality and production of estradiol goes down, then the brain senses this and says, oh, I need more estradiol produced. So it triggers more production of LH and FSH from the pituitary gland. Now, when you produce more LH, the precursor to all estradiol, 100%, no exceptions, is testosterone. So the ovary makes testosterone in one group of cells, and then the testosterone that's produced travels, goes to another part, to the granulosa cells, where it's then converted through the enzyme aromatase into estradiol. And when things are right, you have this other little hormone called anti-Mullerian hormone, which is a crazy name. I wish they would change it to follicle recruiting hormone, because in the ovaries, that's what it does. And it recruits all these little follicles, and each one is saying, choose me, I want to be the ovulating one. But ultimately one, or sometimes two, then you get twins, is chosen. And that's done through some magical thing. We don't totally understand which egg is chosen, but it gets ovulated out after you get an LH surge, and then you have a little FSH surge. And then that shuts down the production of anti-Mullerian hormone. So you stop making and recruiting all those follicles, you get the ovulation, and then you have what's remaining turn into the corpus luteum. That's another structure in the ovary that produces the progesterone. So what happens, though, as you're transitioning into the menopause, is that you have higher amounts of LH and FSH produced, because the ovary is less responsive. But if you push it hard enough, kind of like, once again, like think of insulin resistance in the stages that evolve into diabetes. When you're in that pre-diabetes phase, your pancreas will make more insulin. And when you have more, it will help control the glucose and help get the glucose. So you can have normal blood sugars, but if you check insulin levels, they'll be high. So you can still sort of have normal estrogen levels, but the FSH and LH can go up and down and be higher. And what happens when you have more LH is you will make more testosterone. That's why many perimenopausal women will say, what the heck? Talk about reverse puberty. Why am I getting acne? Because they actually are making more testosterone, because that's the precursor to estradiol. And the brain is saying, please, ovaries, give me more estradiol. And so the only way to get it is by making more testosterone. But if you have like a little glitch in the production line, and so you're not converting it as efficiently or as well into estradiol. You end up with a surplus, too much testosterone, and then suddenly, what the heck? Like, why am I getting like whiskers? Like, what the heck is this? And so many women, as they're approaching menopause, like, what is happening? I'm getting acne, I'm getting facial hair. And not only that, where's the hair on my head going? I'm getting androgenic alopecia. So this is like a problem. And no woman likes this at all, but this is part of that process. Now, in addition, the estradiol level that's produced is going to be less. And then they're going to often make a lower amount of progesterone. So this can change how the uterine lining is growing and then shedding. So you can have changes. You can have some irregular spotting. You may have mid-cycle spotting. You may skip ovulation altogether some months. You may have heavier bleeding because you don't have enough progesterone to properly convert the lining into what we call secretory. So estradiol is a growth type of hormone. Now, some people think that's bad, evil, growing. No. Growth is what we do when we rejuvenate, when we heal, when we replace dead cells. That's how you get a burn or a cut on your skin. Estradiol to the rescue. In fact, the skin makes estradiol. That's how men get a lot of estradiol. They make it from their testosterone through the enzyme aromatase that's present in many organs peripherally. But after menopause, well, women don't have a lot of testosterone. So they, and their systems aren't really set up to do that to the degree that men can do it. But that's how men have tons of estradiol in their body, but it's produced locally from their testosterone. It's not circulating. But, so it's really important for men to have plenty of testosterone. Like I said, when they did studies in older men, they did great when they had adequate amounts of testosterone. But a lot of the action is actually by its conversion into estradiol. So the bottom line is a growth hormone is essential for rejuvenation, for neuro and mitogenesis, to create new neurons, to create new cells. So it helps to create like vascular endothelial growth factor, brain-derived neurotrophic factor, things that create new blood vessels, new tissue, brain health. But you, like all growth, you want to have controlled growth. You want a city that just grows out of control? No, and the part of the control system for the estradiol is the progesterone. So progesterone, when it comes on the scene after ovulation, it stops that growth, what we call proliferation. And it changes into this like lush garden that we call secretory. And then when you're not pregnant and the progesterone drops sort of, pretty acutely, then everything sheds out. But what happens when you don't have enough progesterone because you're not making good ovulations and you're not, things are not quite right, the corpus luteum isn't right, and you have a shorter luteal phase, so you're not even getting as many days of your progesterone, and you don't make the proper secretory status, you don't have proper complete shedding. So if you don't get all the dead lining out, then it keeps kind of trying to get out, and blood vessels are open, and that's where the blood is coming from. What the menstrual period is about is trying to get rid of the tissue. The blood just comes along for the ride, and you also need to have the myometrial cells, the muscle cells, to contract, to act like a tourniquet on those blood vessels. But a lot of that is triggered through systems of calcium channels and everything that are all hormonally controlled. So if your hormones are even a little bit out of whack, all these systems can be a little bit offline, so they're not working properly. And that's where sometimes giving supplemental bioidentical hormones, as opposed to birth control pills, which are endocrine disruptors and shut down your hormones altogether and have a lot of other negative effects, that you can try to supplement with human bioidentical hormones, understanding what's going on. And you can actually measure the hormones through an entire menstrual cycle with menstrual mapping. Of course, it's one cycle, and that's not necessarily every cycle. There can be different, but you can get a good idea. So you don't even have to be guessing. You can actually measure, or of course, sometimes you could just give it your best clinical guess as well. But understanding the mechanisms will help prevent a lot of surgeries, especially like hysterectomies. And by the way, they now have shown that the uterus has a communication with the brain. Isn't that interesting? That if you take the uterus out before, well, nobody's done the studies in really elderly women, but in women who still have functioning of their ovaries, you actually have some cognitive decline. The uterus, everything's more complicated than we ever guessed. So if you don't need to take out an organ, then please don't take out the organ. Don't say it's past its prime or you're not going to have babies anymore. Things are more complicated than we ever thought, the way that there are signaling agents and things communicate. So, if you have to, if you have cancer, that's another story, but don't take it out if you don't have to take it out, especially like in your circumstances. Even the fact that that was offered makes my hair stand on end, but the thing, and by the way, the Mirena IUD is not a progesterone IUD. It has levonorgestrel, which is a multiple endocrine disruptor, and it does get absorbed systemically. And half of women stop, the first couple of years or so at least, stop ovulating. So it's going to change their estrogen production and their rhythms. So, you just have to call a spade a spade. Sometimes you have to give pharmaceuticals, including contraceptive hormones and so on, to control like out of control bleeding while you get things under control. But, it's not supposed to be a long-term solution, and it's not giving women hormones to control. They're not human hormones. I wish they would just call them endocrine disruptors instead of hormones, because it gives people the wrong idea. It's like, like you wouldn't lick plastic every day and say, I'm getting my hormone dose. But that's how I see it with the skull and crossbones, slow poison. It's not going to kill you, but there's a lot of slow poisons. We live in a world of slow poisons. So, we definitely don't want to intentionally put them in our bodies. We get exposed to enough unintentionally as it is. So perimenopause is really interesting because you can have giant spikes. So when your estrogen level goes down, and then the brain says more estrogen, and I'm saying estrogen, and it's estradiol. And so it ups the FSH and LH. So you get this big surge. And then if you're still got functioning ovaries, although not so great, you may put out 2 eggs. And then that's why women in the perimenopause, early 40s, for example, have more twins, fraternal twins, than at any other age in a woman, because of this like hyperstim. It's like what we do if we're collecting eggs for, egg freezing or to create embryos for IVF. We hyperstim because we don't want to have women go through like hundreds of cycles where we get 1 egg each time. So they try to hyperstim to get a bunch of eggs out, and they use like FSH, LH equivalents. But the nature can do that, and you can hyperstim yourself. And part of, so you could get pregnant with twins if that could happen. But if, say, that doesn't happen, what happens when you hyperstim? You produce more estradiol. So this is the only time in a woman's life when she can make crazy amounts. So normally, even at the peak of estradiol, it's under 500. That would be the one day when she has her spike. But I've seen levels in perimenopausal women, 800 something. It's like, no wonder they don't feel great, because estradiol is wonderful, but women who get hyperstim, like when we're doing triggering, for egg collection or for embryo making, that's a dangerous thing when you hyperstim and you make too much estrogen. Like you can die from water, but you can't live without water. That's, you can always have too much of a good thing. And too much estradiol can be responsible for a lot of the terrible symptoms, like suddenly having migraines and edema. So estradiol is more like fluid retaining, whereas progesterone is more like a diuretic. Everything is yin yang. I don't know how the Chinese were so smart, the push, pull, hot, cold. And so you have this, fluid retention, fluid, exit. And so if you have really, really high estradiol, you can have like, suddenly I'm like puffy and I have bloating, and estradiol tends to be more constipating, progesterone, the, more laxative effect. And so I'm like constipated, I'm bloating, I have a headache, oh my gosh, and it's, the good news is it's temporary, because that's like, I liken it to if you go to a fireworks show, and right before the end of the fireworks and the whole show is over, they have this unbelievable display. It's like the whole sky is lit up with all these fireworks, and then boom, total blackness, right? So that's what you get. You get this explosion of estradiol, and then poof, it's all gone, then like, this is like craziness, but this is like the years of it. And then in terms of mood, because of these fluctuating hormones, and then the ultimate downward. So it's like you're going down, but along the way down, you're getting these giant spikes up. Okay. So, wow, what a roller coaster. But because the ultimate trajectory is down, and estradiol is anxiolytic. It reduces anxiety. It's a mood stabilizer. And a lot of this probably works through the endocannabinoid system, like maybe for another day. That's a whole, like fatty acid, these come from omega-6s. That's why I have to defend omega-6. They're not pro-inflammatory. They are if you get them from processed food with oxidized oils, but it's essential to life, and they're not pro or anti-inflammatory. They're directed in the direction the body needs them to go, depending on the situation. And the whole endocannabinoid system derives from omega-6s, and they are, anxiolytic. They help reduce anxiety in the right amounts. Anything, like people who smoke too much marijuana, which I'm not advocating for at all, they can actually have anxiety, and they start slow, so everything's, the dose is, the poison, or whatever that expression. So how much you get triggers how you respond. So, but you need to have estradiol for mood stabilization, and progesterone as well is neuroprotective and calming. That's why a lot of women who take oral progesterone, they say, wow, I'm so calm. It increases GABA, you sleep better. So all of these things are amazing. Guess what? When you are having these big dips and it's going down, women in the perimenopause are double the risk, double the incidence of anxiety and depression. And if they have a history in the past of like postpartum depression, PMS, or just anxiety, depressive disorders, their risk goes up 400% that they'll have a mood disorder as they're transitioning through this time into the menopause. And that's why huge numbers, percentages of women in their 40s are put on mood stabilizers and antidepressants. And it's like, hey guys, how about some hormones? So here's like sort of a trick, like part of the reason, or like the reason why you get these crazy swings and it's going down, is because the brain is sensing, I don't have enough estrogen. And then it's like, now I have too much. Now I have too little. Now I have too much. So, the brain is like, I'm trying my best to get this regulated. These ovaries are not cooperating, So if you give some estradiol so that the brain always has the feeling, and it's true, it's not a phony feeling. It's like, this body, this woman's body has enough estradiol. I don't need to put out a crazy amount of FSH by stimulating the pituitary. By sort of stabilizing things, the brain won't feel the need to overstim and then understim and then overstim and then understim. So giving perimenopause, and this is not conventional, this is not, and this doesn't make any sense, but this is not, they'd rather give antidepressants and tranquilizers and gabapentin and all these other drugs that have a lot of side effects and negative effects, that they're willing to give those drugs rather than give the body what it's crying out for. Like, how about a little stability with some hormones here? And if you do that, you can totally change the paradigm of what perimenopause is like. But rather than shutting down the ovaries, I mean, that's another option. You go on birth control pills, and some women like that, but they're not realizing that that is actually not a health pill, because it's like taking that ground up plastic cup and then swallowing it every day. And I know that sounds so crazy, but it isn't, it's really an endocrine disruptor. In fact, you can go to toxicology.gov. That's part of the NIH, National Institutes of Health, and you'll see every component, every ingredient in a birth control pill officially listed as endocrine disruptor. I'm just calling a spade a spade. I don't want to take them. I get enough of them just by, breathing the air and, eating food that I can't help. It's packaged in plastic, like you can buy the most expensive grass-fed beef, and by law, they have to ship it to you from another state encased in plastic. It's like, what the heck? You can go to a store and you get organic apples and they're all encased in plastic, individually. And that, we'll talk about waste. Don't do that. Don't buy apples in their own individual plastic containers. Okay, please be an environmentalist. Our planet will thank you, and so will future generations. But and your own health will thank you, because plastic is not what's the minimum daily requirement of mercury? Oh, 0. You don't need any plastic. It's not considered a nutrient that you need. You have an RDA. Like how much should you get every day? So we want to avoid that, because that just compounds the problem. I can tell you, for perimenopausal women, if they have a high toxic load on top of having hormonal crazy fluctuations. But it's an exciting time, you can certainly say, with mood swings. And of course, it translates into lots of sleep issues. Oh my gosh, because, talk about the neurotransmitters. It turns out that estradiol is critical for serotonin neuron function. Serotonin is made in the brain. It's also made in the gut, as we know, but it's made in bones. It's made in a lot of places. Everything is multitasking, but in the brain, serotonin is very important, and it's like for mood, and also works on cognition as well. And serotonin is the precursor to melatonin, which is not optional, as a very potent, like the most potent renewable antioxidant in the body, and of course related to sleep. And that's why when you are sleeping, if you go to bed at a reasonable time at 2 a.m., you have this giant surge of melatonin, which is so wonderful. And at the same time, you have this big blood flow surge to the brain and all of that. But it isn't going to happen if you're not having proper sleep and you don't have enough serotonin produced and so on, which is what's happening in women, because you need to have the proper hormones to make these neurotransmitters properly. And that's like not a little matter. Acetylcholine, which is the neurotransmitter involved in cognition. In fact, that's the neurotransmitter they're trying to increase with Alzheimer's drugs like Aricept, but doesn't really work. But nevertheless, that's the attempt. That's the theory. And so acetylcholine is also critical. And dopamine receptors don't work properly without estradiol. And we can go on. I mean, these are not little things. And so all of this is related. So you have mood problems, you have sleep problems, and the immune system, every immune cell, because of pregnancy, you have to regulate the immune system. You have to downregulate the innate immune cells and so on during pregnancy, so kill the fetus. So all the immune cells, every single immune cell, and women are robust. They have a bigger immune system, like more aggressive and responsive immune system than males. And that's why women survive infections and sepsis better than males up till menopause, and a little bit more just because we got that extra X chromosome. Another story for another day, but we're a little special because we have 2 X chromosomes and men only got 1. So that actually gives us an edge in survival. That's one of the reasons why we tend to live a little bit longer, but we live a lot worse. That's the problem. Women have way more chronic disease than men. Unfortunately, I had to detail that in my book. It's kind of little, but I tried to make everything up, like happy, because we can do something about it. It's not all bad news. But when you look at like who has more joint replacements, osteoarthritis, women. Who has 80% of the osteoporotic fractures? Women. Who has twice at least as much mood disorders, sleep problems? Women. Who has more gastroesophageal reflux after menopause? Women. By age 65, who has more strokes, ruptured aneurysms? Women. Who has 2.5 times or more the amount of Alzheimer's disease? Women. Come on, we will live a little longer, but oh my gosh, we have way more chronic disease. And once you hit 65, 75% of women have high blood pressure. Once you hit 65, at age 65, 75% of women have high blood pressure. By age 75, it's 85% of women have hypertension. When you go through perimenopause, what else happens? Insulin resistance and impaired gut barrier, leaky gut. So the gut microbial population varies depending on your hormonal status. And this has been proven. This is not conjecture. This is proven that when you have altered hormones, as you go through perimenopause, the microbial population in the gut changes, and not for the better. So by not having the right microbes, then this leads down another whole chain of events. You don't produce the proper metabolites, the short chain fatty acids that include acetate, propionate, and butyrate. And they're involved in signaling to the brain, signaling to the liver. And butyrate in particular has binding sites on the vagus nerve, which is a huge part of the autonomic nervous system, and the vagus nerve stimulates the production of the neurotransmitters for the parasympathetic or calming part. So women after menopause and the perimenopause, they're kind of upregulated into a higher stress state because their parasympathetic is like more offline, but the sympathetic ganglion are going gangbusters. So they're much more in a stressed state. So anxiety grows. Cortisol is produced in greater quantities, the stress hormone from the adrenal gland. And what does cortisol do? Well, in chronic elevated production amounts, it further causes leaky gut, impaired gut barrier. It alters immune function and creates more pro-inflammatory state and dysregulates the circadian rhythm, which is already getting dysregulated because estradiol from the ovaries is also a key regulator of the circadian rhythm. So basically, all women, as they transition into menopause, they're living a life of jet lag. So it's like you're traveling across the United States every other day. That is not good. Actually, I did that when I did all those deliveries, all those nights. That wasn't good for me. I think that's why I had that early menopause. Like it wore out my ovaries. They actually show that you can, when you have inflammation in your body, it's in the ovaries too. They've actually done like take out fluid from the follicle. It's all full of inflammatory cells. So, and that it prematurely ages the ovaries, which is so bad for us. So we do not want to have this happen, but we have to have menopause. We can't stop it. I mean, you can delay it a little bit if you eat lots of vegetables and have the perfect lifestyle. Like, unlike me, you might have a little bit, like maybe 2 years later, but it's inevitable. Like you can yoga yourself forever and you're not going to stop menopause. You may delay it a year or something like that. And we do have tricks, by the way, for women who are like heading towards the menopause and they still want fertility. So, there's a few tricks in the book to try to get the ovaries to get a little bit more life in them, but just so long. So, but we can do so much understanding this transition and doing things to help women. And by the way, phytoestrogen foods are amazing. There's Neil Bernard, who's a vegan cardiologist. I don't agree with everything, but I do love his study on this one. And he gave women like a cup of soy, like whole soy, every day for 12 weeks. And these were women who had terrible night sweats and hot flashes. At the end of 12 weeks, they were almost completely eradicated in all the women because phytoestrogens are nature's gift to women. And phytoestrogens are in all plant foods. It's just a question of degree and type. So the famous ones are soy, and I always have to defend soy. Whole organic soy, non-GMO. Whole organic soy is a definite health food. It's also a fertility food, but not processed soy. Soy pretending to be something else, like cheese or burgers or something. No soy hot dogs, please. And so that has in it isoflavones. That's a type of phytoestrogen. And then flax seeds, they're pretty famous, and people do seed cycling for fertility, although cycling is not necessary. There's no data on that, but there is seeds are good because they're phytoestrogens. They help the ovaries. They help the brain. They're very good. And the one that's famous is flax seeds. They have a type of phytoestrogen called lignans. But all seeds, all nuts, all grains, all beans, legumes, like soy is a legume, they all are phytoestrogens. And then like fruit, like red grapes, they have resveratrol. That's actually a phytoestrogen. Pomegranates, which has fame as a superfood, pomegranates have ellagic acid, another phytoestrogen from which derive urolithins, A and B. So most all the foods that are known as superfoods and health foods, they're really phytoestrogens, these magical ingredients that are not estrogens, but they combine to estrogen receptors and help to make the body in every organ system healthier. But by combining lifestyle approaches like what you eat and exercise, which will trigger the production of the sirtuins as well as fasting. Exercise is known as a fasting mimetic. It like mimics the same effect, like that little stressor on the body, but none of these things work properly in an absence of these beautiful ovarian hormones. And it's not just having them. You have to have a physiologic level. And ultimately, I'm trying to get into a study going to look at mimicking the menstrual cycle. And that's been talked about for 20 years, but we have no data. We don't know how to dose it. We have to have data. We can't just be mavericks and do whatever the heck we want. But, when you know physiology, when you know the ups and downs of the the genes like tumor suppressor genes that are triggered by the different levels, the up and down regulation of receptors, that it's not just having hormones, it's the rhythm of hormones. It's like, just like we talked about in the beginning with food, it's not just what you eat, it's when you eat, everything is timed. We always want to do things, at the right time. It's like we want to eat, we want to not eat, we want to have hormones, and then we want to have lower hormones, upper, like the beautiful rhythmic menstrual cycle. It's not the same level all the time, and it does turn on and off genes. These hormones work to, with gene expression and turn on and off genes. And then the genes in turn make the enzymes like the sirtuins, and they're involved with the coenzymes. And it's just a beautiful, amazing story. But this story does not have the ultimate happiest ending if you don't have those hormones. So that's why I defend the defenseless. I defend soy. I used to have to defend fat, but I don't have to do that anymore. And now I have to defend carbs, but only whole carbs, non-processed carbs. And I have to defend estradiol, estrogen in that form, and real progesterone, because these hormones, starting with the Women's Initiative, it just took us down the worst possible road of misunderstanding. And then I call it mistreatment of women. So they're not getting informed consent. Every woman can decide, I don't want to have hormones. It's an individual choice. But how can you make an intelligent choice if you don't even have the foundational information on which to base it? And that's what they're not getting.
I so agree. And it's interesting, as I was taking notes during our conversation and referring to oral contraceptives as endocrine disruptors, and how many women of my generation took years and years and years of oral contraceptives to control our menstrual cycle or our symptoms, not realizing that we really never got informed consent. And the same goes for hormone replacement therapy. And I love your book, Menopause, 50 Things You Need to Know. And I even told Dr. Gersh before we started recording, I said, there were things in here that I didn't know. And I'd like to think I'm fairly savvy with the research, including things like body odor changes.
I know, because all the microbiomes, that's like once you know that estradiol, we'll just say estrogen, is key to every organ system functioning. And that includes the microbiomes of every organ system. We now know the gut, and most women now know, and who are in our business, they know the vaginal microbiome, but they often forget things like the eyes, like the skin, and the microbes that live on the skin, the way that they metabolize sweat and so on, and how we even produce sweat, will lead to different scents. And it's so funny because anytime when people go into like an old aged home, there's like a different smell. It's like, this place smells old, and now we know. But, and what's also interesting is pheromones. Well, I don't really talk about that, but because it's not really a menopausal thing, but pheromones are those invisible scents that animals have, insects have, that attract the other sex and also help you to be attracted. And when women are on oral contraceptives, and also in menopause, they stop producing pheromones, the like mysterious, like magical sexual attractant. And honestly, I can't prove this, but I think that is underlying a lot of male behavior, that when they have like a midlife woman in their life, whether, a partner, wife, and then they suddenly start being attracted to another woman that they don't even know why, because it's not like conscious. It's like how we're programmed, because we are in the animal kingdom, even though we like to think we're computers or something, but we're really animals in the animal kingdom, and we have programmed systems. And the men naturally are attracted to these female pheromones, and the wife or the partner no longer has them. And women on birth control pills don't have them. And so the men, like they're genetically programmed, follow the scent, and poof, and before they know it, they're in an affair. And they didn't really even want to. It's just that they were no longer like physiologically attracted to their partner. And they've actually done studies. This is like peer-reviewed studies, that women on oral contraceptives often do not know how to choose the right partner. And that's not good. They end up, choosing the wrong person, and then they all have miserable marriages or to get divorced. So these are natural things, like animals in the wild, like how do they pick their partners, you know? And they actually, it's through these magical things, and they somehow they're designed to get people to be with the right person or the right, you know, the right partner. So anyway, I think they actually did a study. This is so interesting. They took women's panties when they were ovulating, and they rubbed it onto a chair, one chair in a room, and put the chairs in a circle, and they changed the position of that one rubbed chair with the panties. And I mean, these were clean panties. They just were worn by a woman who was ovulating. And then they got in a bunch of young 20-something males, and they thought they were coming on a pretense to like do a movie preview, and they were going to like critique the movie. And they said, before, let's just take a seat anywhere in the circle. And one guy would come in first. And they pick any seat, just pick any seat. They're all in a circle. He would always sit down on the one where the panty was rubbed, and he had no idea why. So how amazing is that? So this is my personal theory, that when women lose their hormones and they lose their pheromones, their spouses and themselves, part of losing sex drive is they're not putting out the pheromones. They don't perceive the pheromones of the men either. It's like all lost. But if you get on hormones, you're going to recreate those pheromones so that you'll be more attracted to your partner. The partner will be more attracted to you. Well, you know, because you know how there's so many times when women are going through menopause and they've been married for like 25, 30 years, and suddenly they get divorced. Like, you know, this happens all the time. I say, like, what is with this? Like, you know, they always say, well, the kids grew up and left. But it's like maybe it's because they don't have hormones anymore, you know? So, because hormones are destiny. They control our brains, our sex drive. Estradiol is big on sex drive, you know, and oxytocin, that's another like hormone / peptide. Its receptors and its production are dependent on estradiol. So there you go, just another one. So yep, so you know, getting back to body odor, yes, that's a hormonally related thing.
There's one death for women every 80 seconds from cardiovascular disease. There's not enough focus and attention on this, especially in this very special time in our lives in menopause, when we're no longer fertile. But this loss of estrogen, unless it's being replaced, has profound catastrophic impact on our health. So from your clinical experience, when you're talking to women that are in perimenopause, navigating that transition into menopause, I'm sure that cardiovascular risk probably comes into the conversation because you're such a diligent and thoughtful provider. But I thought it would be interesting for listeners to fully understand and appreciate how much estrogen impacts immune function, inflammatory response, healing in the body, etc.
Well, that is for sure. In every single aspect of the cardiovascular system, and you mentioned a whole bunch of them right then, is heavily, I mean, incredibly impacted by female hormones. And it is so poorly acknowledged that that is the case. And it's really very simple when you think about why that would be. It really comes down to survival of the species and reproductive success. So once you acknowledge whether you want to have babies, I keep thinking, I'm like the ultimate feminist. I totally want women to control their reproductive destiny, have babies when and if they want them. But whether you want them or not, you need to understand basic like physiology of the female 101, which is the female body evolved for the purpose of reproductive success. And in a human, that means being able to be fertile, to get pregnant and carry the pregnancy to term without complications for mother or for the fetus, and then to be able to nurse that baby for at least a couple of years, going back, you know, to early times, and then be able to survive to raise that child and several others, to do this repetitively, to raise at least a couple of children to survive to their own sexual maturity. And so to that end, you need to have robust, healthy organ systems of every type. And for sure, the cardiovascular system is critical. When you just recognize even one little fact, which is that the placenta has to have incredible vascularity and blood flow and the ability to deliver all the nutrients and oxygen,
you need to be able to pump at least 50% more blood volume around the body of when you're pregnant. So you have to have a very energetic heart, and that is not really well understood even by cardiologists. And you need to have a vascular system that can be able to improve its state of being in order to create new blood vessels, angiogenesis, so that you can perfuse all the areas of the body on a growing uterus. And it's so amazing, the whole state of pregnancy and how involved the cardiovascular system has to be. And then you end up having the master hormone, estradiol. And that has to be coordinating all the organ systems to work together to keep that pregnant woman and fertile woman healthy and going for many years. So nature, though, has sort of an end stop time, and that's called the menopausal transition, when fertility declines and then is gone. And our beautiful life hormones from the ovary, and though we have the top of the heap is the estradiol, and then its sidekick progesterone, and testosterone is a separate issue because that's really more of that is produced directly or indirectly by the adrenal gland. So that's a topic for another day. But when you lose those vital life hormones and your fertility goes away, it's really important for every woman to realize this is a huge metabolic transition, and not for the better. No matter how healthy a woman is, no matter how hard she tries to do everything right with her lifestyle, she cannot spontaneously get healthier because she goes through menopause, because those vital life hormones are sustaining every organ system, and especially the cardiovascular system, which is the highway of the body, producing the ability to supply every organ system with oxygen and nutrients, and for the immune system to circulate and then be able to help deal with injuries, trauma, dead cells, infections, and so on. And of course, to perfuse that vital organ, the brain, and to take the impurities away and maintain a healthy blood-brain barrier, so you don't have what we call like leaky brain and so on. So it's just an incredible loss of metabolic homeostasis. And when you go detail by detail, which we can do looking at like the specifics of what does estradiol do in the various parts and so on of the cardiovascular system, it is shocking. Like we were chatting before we started about how so many women and their medical providers don't realize this huge shift in the ability of the body to optimize everything, including the cardiovascular system, with the transition into menopause.
What are some of the risk factors when you're doing a history? Maybe you have a new patient, someone comes to you. What are some of the harbingers of concern for you in terms of cardiovascular disease risk in younger women as they make that transition? Because I recently interviewed Dr. Tom Dayspring, and he was kind of identifying these are things that I will lean into. If a young woman mentions she has a history of preeclampsia or gestational diabetes, things that will put people at greater risk for developing vascular issues as they get older.
Well, yes, and we'll go into that in a moment. And just to say, as an OB-GYN, I delivered thousands of babies. This was so evident to me like decades ago, but this is only now just coming out as, risk factors, including pregnancy-related complications. It's like, where have you been, guys? Like, you obviously ignored everything involving obstetrics, because this was so evident, and it's like giant duh, so the biggest stress test of a female is pregnancy. Now, everyone knows a stress test. You get on the treadmill, you have a stress echo, and you put the body under some stress, like you make them run, or you inject something that creates a stress, and then you see the response of the heart, and you see if there are issues. And there, like I said, when you are pregnant, you have to pump at least 50% more blood. It is a huge stress on the heart. If you don't have a healthy cardiovascular system, then you are going to fail your stress test of pregnancy. And basically, when you are pregnant, you become mildly insulin resistant. And there's a purpose to that. When you are pregnant, you develop almost immediately leaky gut. Now, I would say, oh my God, how can you get leaky gut? It's because it's a mechanism. That's why only really healthy people should be pregnant. And that's why only young people are supposed to be pregnant. And the older you are, the higher risk you are. I mean, we've known that in obstetrics forever. A pregnant 40-year-old has a much higher risk, potential than a healthy 25-year-old. So when you look at what is happening in a pregnancy, like with insulin resistance, like you mentioned, gestational diabetes. Well, how do you get fat quickly if you're pregnant in ancient times when there wasn't food at every corner? Well, the way that it happened is nature would make you mildly insulin resistant. And what does that mean? It means that the insulin you're producing is less effective. So you're going to then have your pancreas make more of the insulin. So insulin is the hormone that really encourages the production and storage of fat. That's why pregnant women can eat very little more, sometimes not eat more at all, and they still gain weight because of this inherent insulin resistant status, which is created by a leaky gut. That's why when you're not pregnant, you don't want to have leaky gut, among many other reasons. So you end up having higher glucose levels in your blood, and you'll have higher insulin, and the higher glucose in the blood is necessary because it passes through the placenta into the baby so that you can grow that baby in a relatively short amount of time to get a healthy baby. So you have this amazing system, but everything is like on thin ice in pregnancy. If you don't have good metabolic health going in, then that mild state of insulin resistance turns into full-blown gestational diabetes. That's why gestational diabetes is a thing. And women could have no sign of diabetes prior to pregnancy, and then it seems to like resolve afterwards. But that underlying metabolic, we'll say, sort of dark clouds hanging over that woman, they're still there. And then what happens? They're being okay as long as they have their ovarian function, that magical hormone estradiol, which optimizes glucose transport. It helps maintain proper insulin function. It's just the metabolic homeostasis hormone. So when you lose that, you lose that one thing that was keeping you on track. And that's why when you go through the menopausal transition, women who previously had gestational diabetes have an enormously higher risk of developing regular garden variety, unfortunately very unhealthy type 2 diabetes. What about like preeclampsia or gestational hypertension? Well, if you do not have the healthiest state of metabolic health going into pregnancy, when you're pregnant, you have to then create all these new blood vessels, and you have all these dynamics happening with the placenta, and you have to be able to deal with all of that. And if you have any borderline state of metabolic health, then you may have problems with gestational hypertension and preeclampsia, which is really heavily a vascular disease. And then once again, when you lose your estradiol with the onset of menopausal transition, and then thereafter, you will have a much higher potential to develop hypertension. And in fact, even without that history, by age 65, as a general statement, 75% of women will develop hypertension, or at least they're on the track for pre-hypertension, which is a thing now, recognizing that that's like the early stages, like pre-diabetes to diabetes. But these so-called pre-conditions are not like okay status. They're actually bad status. Things are really happening that are harmful. So we can then use pregnancy as sort of a bellwether of what will happen later in terms of that sort of those problems. But what else? In addition to pregnancy, there is irregular cycles. So we now know that women who've had any history of infertility, any kind of infertility, and if they've had irregular cycles, then they also, and of course, the poster child for that is, of course, polycystic ovary syndrome. They will have a much higher risk of having these metabolic dysfunctions as a transition into menopause. So basically, in now the gynecological world, it is acknowledged, although not necessarily actually acknowledged in a sense that you do something about it. It's written that fertility is a vital sign. Now, what's a vital sign? Like your blood pressure, your pulse, your temperature. So fertility is a vital sign. If you are of the reproductive age and you're a female and you are infertile, you are having any sign, even if you're not trying to get pregnant, you have all the signs of being infertile, like no periods, irregular periods, then that is a big, like bright, like red light going off saying this individual has metabolic dysfunction. That's why it drives me crazy if you just treat them with birth control pills, like it's like a cover up. And that's another risk factor that is totally under acknowledged. Young women, and the data only goes to teenagers, like anyone under the age of 20. And that doesn't mean if you're 21, it's okay. It just means we have no data. And what am I talking about? I'm talking about use of oral contraceptives or similars, that women who are started on them prior to the age of 20 have an increased lifetime risk of cardiovascular events. That's like a big deal because now it is considered in the conventional medical world okay to start any girl, and these are girls, any girl on oral contraceptives as long as you are 1 year out from her first period. That's it. And we have girls who are starting their periods way too young, like they could be 9, they could be 10. That's how you could have the case of a 10-year-old getting raped and getting pregnant. It's like, who could get pregnant when you're 10 years old? They're starting their periods at age 9. That's another thing we'll mention as a risk factor. Early onset of puberty is another risk factor for cardiovascular death or events later on when you lose your hormones, because that is not a good thing to start your period so early. But for girls who do start their period early, or whatever the age it is, once they're out 12 months from their first period, if they have acne, if they have irregular cycles, if they have, cramps. By the way, in terms of cycle problems, it's not just irregular. It's like PMS. It's like really heavy. It's like really painful. Those are all in the category of abnormal cycles in some form or fashion. So any girl who is, in that category, or sometimes they just say, I don't want a period. So the mom doesn't know. She doesn't know. She says, okay, put my 13-year-old daughter on birth control pills because she thinks, well, it's regulating, regulating their periods. And this way, if they're in sports, they don't have their period when they're in competition. I mean, I get where they're liking that concept, but unfortunately, you're affecting basic metabolic functions in a way that is harmful, whether we like it or not. You just have to tell the truth about that. So if you're started on these oral contraceptives or similars, patches, rings, and you're started at young ages, it actually has an impact on cardiovascular risk for the rest of that person's life. And like I said, it's not that if you start when you're 20 or 21 or 22, that there's no risk. We just have no data. And the reason we have no data is because 90% of American females are on some form of hormonal contraceptives by the time they get into their 20s. So there's no control group. Who are you comparing against? They're all in that category. So that makes it almost impossible to then backtrack and see, well, is there an increased risk? It's like everybody. So it doesn't look like there's an increased risk. But, it's a problem because, as you mentioned just at the get-go, cardiovascular events, heart attacks, strokes are the #1 killer of women out doing virtually everything else combined. That's like how big a deal it is. And it would be okay if you said, well, look, everyone has to die. If you die of a heart attack in your sleep when you're 100, that's okay. But we're talking that a very significant percentage are younger women, and like often in their prime. And if you have any of these precursor risk factors, everything kind of gets bumped up by a decade. Another risk factor that doesn't really get its fair share of attention is early onset of menopause. That is a big deal. And it's so shocking when you think, well, if you start your menopause at an early age, and if we look at what menopause categories are, so normal is considered 45 to 55. So that's a whole decade right there that's considered normal. And the definition of menopause, which is totally arbitrary, is 12 consecutive months without any vaginal bleeding. And I say vaginal bleeding because if you go 9 months and you have no bleeding and suddenly you start spotting or bleeding, the last thing as an OB-GYN that I would assume is that after 9 months you spontaneously ovulated. I would call that abnormal bleeding until proven otherwise, So, I mean, we don't know what that is. We don't know what that bleeding means. And in fact, when they talk about late onset of menopause is a risk factor, it's like, hey, you guys, that's because you have a crazy definition of menopause. You're saying any bleeding counts as like start from square one again, like if you go 9 months and then you start having spotting, that means the clock starts over again. So, and then you wait another 9 months and then you have some more little bleeding and the clock starts over again. So they say, well, if you have late onset of menopause, that's a risk factor, but that's because these women aren't actually ovulating. These are not normal cycles. This is dysfunctional uterine bleeding, or it could be even worse. It could be endometrial hyperplasia, adenomatous or precancer, or even endometrial adenocarcinoma. We don't know what that bleeding is if you don't investigate it, but that's not like you're still ovulating. But they call that late menopause. That's not late menopause. That's ongoing abnormal bleeding that's going on for years and needs to be it needs to be evaluated and needs to be addressed, but they'll put that into that category. That's why that is nonsense. If a woman has normal cycles and she has a later onset of menopause, that's a good thing, not if she has random bleeding going on sporadically for years. So the normal menopause is supposedly 45 to 55, and that's when you actually have no more periods. So late menopause is over 55. Early is 40 right up to 45, and premature is prior to 40. The earlier you lose your ovarian function, the worse off you are. And that is proven without a shadow of a doubt. These are life-giving, supporting hormones. And so it is a risk factor for earlier onset of every cardiometabolic. So we put that together, cardiometabolic. So metabolic would be things like obesity and diabetes and all the unbelievable risk factors that come along, like kidney disease and so on, that are part and parcel of diabetes. And it's when you actually break it down, well, like what does estradiol do? Like we talked about cholesterol. Well, it has a huge role in the liver production of cholesterol, where 90% of the cholesterol circulating in the body comes from liver-produced cholesterol. It's not, only 10% is from diet. And then if we look at, the liver and the production of cholesterol and the recycling of cholesterol, all of that is under the control of estradiol. And then if you look at just every aspect of vascular health, everything, all under control. And I had a paper published about not even a year and a half ago that was in Mayo Clinic Proceedings on the renin-angiotensin-aldosterone system, which most doctors, even cardiologists, think it's evil. They think down with that system, like it gives you high blood pressure. And we have a lot of pharmaceuticals that are addressed at modulating that system. You may have heard of some of them, like ACE inhibitors and the ARBs, the angiotensin receptor blocker drugs. So these are things like lisinopril is an ACE inhibitor and losartan is an ARB. So these are really common drugs, and they're modulating this RAS system, the renin-angiotensin-aldosterone system. Well, estradiol is the master regulator of this system, and this system has two branches, an anti and a pro-inflammatory branch each, and without estradiol, it defaults into the pro-inflammatory branch, and that causes vasoconstriction because it's a life-saving system that's really designed to modulate how the body responds to a stress, like an infection trying to take hold in you or an injury from trauma. And if you just think about it, if you are in an injury situation and you have a big laceration, your body is going to want to constrict your arteries so that you don't develop hypovolemic shock, right? So you want to maintain your blood pressure so you don't die from shock. And then you're going to want to clot because you want to stop that bleeding. So you're going to aggregate your platelets and activate them to create clotting. So that, and then you're going to want to activate your immune system because you don't want infection, bacteria to come into that wound. So you're going to activate your immune system to go and run to the scene of the injury to start exploding with their inflammatory cytokines to kill any invading pathogens that are trying to get in. And then that's like the pro-inflammatory stage. When you don't have enough estradiol, you stay in that situation. So you have vasoconstriction and your platelets are in a more pro-clotting situation and your immune cells are in a active pro-inflammatory state of creating inflammation, even when there is no invading pathogen and there is no damaged tissue that needs to be addressed. And then the estradiol not only institutes that inflammation, but it also goes into the off switch so that you go into the healing resolution. So you have growth factors, healing factors, you can create new blood vessels, new tissue. All of that is under the control of estradiol. And in the normal state, when you're not injured, when you don't have a pathogen trying to invade you, you are in the calm anti-inflammatory RAS system where the blood vessels are dilated and you don't have constriction, so you don't have high blood pressure, your platelets are not activated, you don't spontaneously clot, you don't have activated immune cells, so they're not creating the inflammatory response anywhere in the body, and you're healing and maintaining all of your tissues because you're in that sort of maintenance state where everything is kind of being surveilled and maintained in a good calm state. So it gets so confusing even to doctors because they don't understand that in order for this system, this RAS system, which is so critical for survival, to be properly modulated and not be in the default pro-inflammatory state in that whole pathway, you need to have estradiol, and they get mixed up because when women go on birth control pills, for example, or they're given, like in the Women's Health Initiative, conjugated equine estrogens that are given orally, those types of estrogens are different from estradiol. Well, the birth control pill estrogen, ethinyl estradiol, is technically an endocrine disruptor or a xenoestrogen, and the conjugated equine estrogens, when given orally, contains a whole array of different things that you would never even have in a human body, but both of them primarily will turn into estrone, which is a different type of estrogen. So it's important to understand that estrogen is not a hormone, it's a family of hormones. And just like B vitamins, there's not a B vitamin, there's a vitamin that has a big letter B and then a number and then a word that goes with it, like B1 is thiamine, B12 is cobalamin. Well, estrogen has a big letter E and then a 1, a 2, or a 3. There's a 4, but that's a fetal estrogen. We won't go there. And the 2, E2, is estradiol. That's the one that the ovaries make. E3 is estriol. That's the one that's the dominant one of pregnancy that the placenta makes, which creates a whole different scenario of your immune system and leaky gut. You don't want to try to recreate pregnancy in a non-pregnant woman. Not that you could anyway, but that is never our goal. That's nonsensical. And E1 is estrone, which is in balance with estradiol in a normal, healthy, reproductive female as the body needs it. But those other estrogens, like from the Women's Health Initiative and in birth control pills, they turn primarily into estrone. Estrone acts on one receptor, and estradiol works on all the receptors for estrogen and in a balanced way. And if you think of it in sort of simplistic terms, E1 operates the receptor that is on immune cells called innate immune cells. They're the primary first responders if you have an injury or an infection. So you're like turning on the switch for the immune system to be in an activated pro-inflammatory state when you have predominantly E1 in the body. And that is a problem. And that also is the estrogen that is made in fat tissue under an inflammatory state, which is what happens to women after menopause because they go into that pro-inflammatory state, which some clever person termed inflammaging. But it's only that pro-inflammatory state because you don't have the balanced estradiol and you go down the default pathway into only the pro-inflammatory, and it's fed by inflammation, even causing more estrone being produced by the transformation of adrenal androgens. They're like male type hormones, but women have them too. And the bulk of them come from the adrenal gland. And they're like DHEA, DHAS, you may have heard of those, and they get converted into estrone. And there is an enzyme that can convert estrone to estradiol. But when you have a lot of inflammation, that enzyme is downregulated, so it works less well. So you sort of get stuck into producing all this estrone, and it's stuck as estrone, which turns the on switch for inflammation. So you're in this pro-inflammatory state that's like, gets like the snowball effect, because you then have more inflammation, which then causes more of this estrone. But that is not the same as having estradiol from your ovary, and doctors don't seem to get it. I mean, it's not that hard. It's not rocket science that you have different estrogens, they have different effects, and if you have the wrong one, you get an imbalance of how the immune system is responding. And people know this with fats. That's another like good analogy. Like if you have someone who's eating lots of processed food and it contains a lot of trans fat, which you're not even supposed to have, but put into these foods, but it's also converted from processed oils and stuff. You can actually, not intentionally, but it turns into trans fat. But when they used to put trans fat in on purpose. So these were very bad for people. Trans fat is very bad. So you wouldn't say never have food with fat, although they did say that, but that was wrong, right? Never eat food with fat because fat is evil. Well, trans fat is evil, but omega-3 and the monounsaturated fatty acids from like olives and the best type of olive oil, and if you have walnuts that are nice and fresh, or you have to have fat, from avocados, they're called essential fatty acids. You have to have fat in your body to survive. And so you cannot equate evil trans fat with these healthy essential fats. But that's what they did to poor estradiol. It's like the evil twin. And, you have these other estrogens that would never even be in a human body, like ethinyl estradiol from a birth control pill, or the horse urine product that would never be in a human body. And you put it into dry it, put in a tablet, and then you take all the bad stuff that happens, and then you put it on the poor estradiol, and then women don't get proper treatment and they learn to fear their own beautiful hormones. And it's so simple. Once you just get down to it and you look at all the amazing things that estradiol does throughout the cardiovascular system with the enzyme systems that it controls. And we can, if you're interested, we can go into all the different enzyme systems, which are fascinating, that are all modulated, and not just the ones that are in the pathways of the RAS system. It's like a whole slew of other ones as well. But once you understand that fertility is a vital sign, that nature made it so that women would be optimally healthy during the reproductive years, and that estradiol is the master of everything that has to do with on-off for inflammation and vascular health and heart health, the myocardium, the conduction system of the heart, so you don't have palpitations and atrial fibrillation, which is now rampant after menopause. All these things are under the umbrella control of estradiol. And when you lose it, you lose all the controls of these systems. And so if we just think of menopause as what it is, it's really simple. It's a hormone deficiency state. And we treat it like any other hormone deficiency state. If you don't have thyroid because you had to have your thyroid gland removed, or you get Hashimoto's and you're not making thyroid properly, nobody would say, whatever, like just eat more vegetables, or just suck it up. Nobody would say that if you didn't have thyroid hormone, or you can name any other hormone. If you have type 1 diabetes, we would definitely give you insulin. We wouldn't say, too bad for you, you can die. We don't do that for any other hormone deficiency. Why would we treat menopause differently? It is natural, but so what? It's naturally the end of metabolic wellness in the female. So it's so simple. And just think of it as what it is, just a hormone insufficiency state when you're perimenopause and a true deficiency state when you're in menopause.
Such a beautiful explanation. And I love that you touched on, menopause is natural, but it's not optimal. And I think for many listeners, when you ran through the list of things that can put us at greater risk for developing cardiovascular complications in menopause, that encompasses a large percentage of women. I think just the infertility and oral contraceptive use in and of itself, how many of my generation were started on oral contraceptives in our teens because of irregularities in their menstrual cycle. And at that time, I had very irregular cycles. I had thin phenotype PCOS. So not surprising that that was the effective fix for that problem. But for people that are listening, I'm curious when we're talking about timing of hormone replacement therapy, we're talking about whether in perimenopause, transitioning into menopause, or starting in menopause. I know there's this role of timing. There's this hypothesis, which I think we've learned that we have windows in which it's optimal, most optimal, but it doesn't necessarily mean that if someone's 10 years in that they may not be a candidate. That really looking at healthy endothelial tissue. So we're looking at the lining of these blood vessels and the progression of, cardiovascular disease risk. What are your thoughts on timing? Like when you're working with your patients, I'm sure you're probably having conversations in their 30s so that they're getting prepared for perimenopause and then later menopause. But if you had an optimal window in which you like to start HRT, where is that window for most people? Again, not medical advice, but kind of broad sweep strokes on where you like someone's hormones to be optimized.
Well, if you could know when the last ovulation would occur, the last period, which no, they don't exactly match, but they're similars, then it would be at least 5 years before that, or up to 10 years before that, because we now know, and this is not controversial, that bad things are happening in many organ systems, like bone is being lost, and bone is actually part of the cardiometabolic system. It's not just a structural, like, creation. It actually is a hormonal organ. It's an endocrine organ. It actually makes a hormone that helps regulate brain cognition and also glucose regulation. So everything turns out, makes hormones, like muscle makes hormone. Everything is like, so even the things that you don't even think of as endocrine or hormone producing are really part of this whole cardiovascular system. So bone, cartilage is lost years before the last period occurs. We know that plaque is forming and vascular changes are occurring years before the last period happens. Brain cognition issues, even like vaginal dryness and sexual changes, sleep changes, mood changes, all these things can long precede that so-called diagnosis of menopause. So we need to recognize, that's why I said perimenopause is hormonal supplementation. We wouldn't wait for someone to have zero thyroid hormone production before we would give them thyroid supplementation. Nobody would expect that to happen. That only happens if you have irradiation like radioactive iodine or have your thyroid surgically removed. It's never a zero thyroid production otherwise, but it's too low. It's too low for optimal health. The same thing, once we just say it's an endocrine organ, we need these hormones, it's a hormone insufficiency, we need to supplement it to get it closer to optimization. And that's part of the problem because it's never been viewed and still isn't viewed as just a hormone insufficiency deficiency state. It's only viewed from a symptomatic state. It's like, well, the only symptoms that we treat are night sweats and hot flashes. And if you are not in menopause officially, by the definition, we wouldn't even think of treating you in the conventional world with hormones. We would give you now there's, new drugs that are neurokinin, 3 blockers. I mean, antagonists. It's like, we have all these new drugs, or we would give the old time like gabapentin, or we give an SSRI. We'll give you some Paxil, or we'll give you Prozac or something like that for your hot flashes, or, a tranquilizer, and then a sleeping pill. And it's, this type of approach, not, you obviously have a hormone insufficiency, we'll give you hormones. No, that isn't the way it goes. And of course, I view it differently. You view it differently. If you are insufficiently producing a hormone, which happens years before, and that's why I love doing menstrual mapping, because we can actually get multiple samples throughout a menstrual cycle, even a woman who's having still regular cycles, and then see, oh my gosh, here's like an optimal menstrual cycle hormone mapping, and here's yours. You ovulate, but like the spike of estradiol that precedes the spike of LH that triggers ovulation, the normal spike, we'll say, is like this, okay? And this is you. It's like a little bitty bump. And then the LH should be like this. And it's like, yours is like this. And then the progesterone goes up, but it should be like this, like a big, like rounded mountain. Okay. And this is yours, so you have, and then it's usually the cycle is shorter because it's an insufficient luteal phase. So you don't make progesterone long enough or in as much as you should. And the estradiol is, the spike is responsible. It's not, creating an optimal ovulation because you have older eggs. Egg quality is diminished. So you end up with poor progesterone production, shorter luteal phase. That's like classic, for having perimenopausal cycles. They're shorter, and a lot of women will have, a lot of changes in how they feel about everything in their body. Just things are different. And often the estradiol is significantly reduced when you look at optimal cycle. And so depending on where they are and how the actual hormones look, in the early part, I may just give them a phytoestrogen supplement that, because phytoestrogens, those are the estrogen-like products. They're like magic sauce of fruits and vegetables, grains and nuts and seeds. It's like amazing that nature gave us this gift of plant-based, pretend but similar and very healthy estrogen-like molecules. And in the very early phases of perimenopause, often that will actually be an okay thing to do, and then maybe give some progesterone. But that's why you have to keep monitoring, because that's not going to hold forever. And then you want to give some estradiol supplementation. So it's like, it's not suppressing the ovaries. It's not like giving birth control. And it's also not contraceptives, which is important to know, because these women in the perimenopause, sometimes they fool us and they get pregnant. And, it's like, surprise. And often it's like twins, because they will, sometimes what happens is the estradiol level goes so low that the brain says, what? I need more estradiol. And it shoots out more LH and then FSH. So, and the ovaries still have eggs, even though they're not the greatest, but they're still potentially viable. And you get like this hyperstim, like you would do to someone if you were trying to collect eggs for egg freezing or for IVF. You get this like hyperstim, and suddenly they put out 2 eggs. And they both just happen to fertilize. Oh, now you have twins. So the highest group of twin babies is actually the early 40s, because they're still sort of fertile enough that they can be like hyperstimmed. That's what you would do if you wanted to get pregnant and you were like 42, and you go to the IVF center and they say, well, let's give you some, medication to hyperstimulate you and get better eggs out, get more eggs out, and of course, in the old days when they did that, you got Octomom, but we don't do that anymore. So, but that can happen naturally with twins, and even rarely triplets, but more twins are much more probable. And so you got to be aware that when we give hormone supplementation, this is not in any way creating a contraceptive, and may even be making you more fertile, because, by giving you the progesterone, that's what we do for people who have short luteal phases when we're trying to help them maintain a pregnancy. So we may be enhancing your fertility, not taking it away. So people need to be aware of that if they do not want to conceive. But remember, fertility is a vital sign, and the more fertile you are, the healthier you are. So, you can also keep that in mind and maybe just use condoms or Phexxi or, a diaphragm, which I still fit people with. And it's not really archaic. It's just coming back in fashion more as people want to try, who are responsible and a little bit older, are responsible to take charge of their contraceptive choices, and they can kind of think about it, and they're more planning and thoughtful, so that they can actually use the barrier methods very effectively, which is much safer, for people who can, be responsible to do that. And so it's definitely time once you are starting to have changes in your menstrual cycle, changes in your sleep. I mean, we got to look for more subtle symptoms than just night sweats and hot flashes. Of course, if you have night sweats and hot flashes, that's like, okay, giant buzzer goes off, you're having something. Of course, you got to check for other things. It's always a rule out, you want to make sure they don't have hyperthyroidism or some other disease, that can give you, or infection that can give you night sweats and hot flashes. But 9 out of 10 plus times it'll be perimenopause. So we definitely would look for subtle signs like palpitations, joint pains, mood swings, sleeping changes, just generally feeling more fatigued, malaise, loss of sex drive. Because a lot of people think, oh, sex drive is all about testosterone. Not at all. Estradiol is critical for sex drive. In fact, it's like the trigger for functionality and production of oxytocin, which is really essential for having orgasmic function, which people don't realize. It's a symphony of all these hormones together. It's not just one. It's like if you had a baseball team, even if you had the best pitcher, that's not a team to win the game. You're not going to win the World Series with just a fabulous pitcher. So you need the whole array of hormones. And at the top, if I was creating like a pyramid, which is like the top of the heap, it's going to be the estradiol. But they're all important. I mean, it's like you need every hormone. It's not like you can live with just one hormone and just because it's the most important, you need the whole team. And so it's just really very detective work to look at, there's some obvious things like the age. Somebody comes in and they're 44. I mean, and they're having even a few of these symptoms. It's like, duh. If you figure you're going to be in menopause somewhere between 45 and 55, most medically probable, you're there, because things are changing years before that last period happens. And so we got to be on this. And if we want to prevent that early loss of collagen and bone and vascular decline and changes in the brain and throughout the whole body, the gastrointestinal tract, like the incidence of colon cancer rises dramatically with menopause. The vast majority of cancers actually occur post-menopause, and that includes breast cancer, which the vast majority occur after menopause. And the ones that occur prior are now, we believe, are mainly related to endocrine disruptors, like the chemicals in our environment that interfere with normal hormone signaling. And so that is really the underlying key. And then plus, tons of unfortunate chemicals in our food, antibiotic use, which has destroyed our microbiomes, and so on. So it's a complex thing, but it's not because you have hormones that you ever get breast cancer. It's in spite of them, not because of them. There are actual mechanisms in the menstrual cycle. That's why the menstrual cycle is to be beloved. We just spend most of our lives as women trying to get rid of it instead of embracing it and understanding that it actually has mechanisms built into it to actually reduce cancer risk. Because when you get the spike of estradiol, it turns on tumor suppressor genes. When you get the peak of progesterone in the second half, the luteal phase, it also turns on tumor suppressor genes. And these hormones turn on and off the receptor functionality. So you have the more receptor function for progesterone when you have higher estrogen, and then the high progesterone suppresses the estrogen receptors. The estrogen rises the receptor function for testosterone, and progesterone decreases it. So we have this yin yang between how the hormones turn on and off the receptors. If you think of a receptor like a mouth, and it can kind of open and close to a certain degree. And these are required for optimal function of all the body, including the immune system and its surveillance. And estradiol also is the key to having proper circadian rhythm, which now we know when it's off, like if you live a life of jet lag, whether it's intentional because you stay up late at night, or you have a shift work type of job, or you're traveling across time zones, or you just have insomnia, whatever the reason, if you're not getting adequate sleep or you're jumping across time zones, you will have higher risk for everything bad, everything from depression, anxiety, diabetes, obesity, cancer, heart disease, heart attacks, strokes, you name it, infertility, every problem is intensified in a negative way if you do not have proper circadian rhythm. And estradiol is a very key part of that. And in fact, the ovaries are incredibly circadian. The ovaries have receptors to melatonin, the hormone that is so key to maintaining our proper sleep, but so much more. Glucose regulation, it's a potent antioxidant, and it's essential for ovulation and proper fertility and regulation of ovarian function and health. So these are really key things. And if without estradiol, that's why so many women somehow, they don't understand what's going on, why they can't sleep. Like you said, suddenly their sleep is gone. And when women were taken off their hormones, when the Women's Health Initiative first came out, and they suddenly, now I can't sleep, I feel horrible. And that increased all their risks for every bad thing that can happen to you. And that's why it's so sad that what happened, even the wrong hormones were better than no hormones. That's like the ultimate, amazing thing, that even those hormones, which were the wrong ones, turned out that for women in their 50s, it reduced all-cause mortality, so by 30%. So if you were on those wrong hormones in your 50s, you had a lower risk of death of every cause by 30%. There's no drug that's ever been created that can lower your risk of all-cause mortality by 30%. And that was the wrong type of hormone. Just imagine if we did a study with the right kind, which is never going to be done because no one's ever going to fund it. So we have to rely so much on science rather than large clinical studies now, because that's where we are. But we have to deal with reality because no one has an interest to fund like another Women's Health Initiative type study using the right hormones. It's not going to happen. So we just have to rely on our wits, our knowledge, our scientific acumen to make our clinical decisions now. It's just the way it is.
Yeah, it's so interesting the way that things have evolved since the WHI, and something that I want to make sure we definitely touch on before we kind of end our conversation is talking specifically about things like in cardiology, I saw a lot of patients with heart failure, diastolic dysfunction. So when we talk about the heart cycle, our heart fills in systole and then gets pumped out of the left ventricle. And then diastole is when, it's this passive filling of blood in the heart. And it's very common to see this in older patients. And so I was fascinated when I was preparing for our conversation, realizing that the changes in sex hormones specific to estradiol actually leads to diastolic dysfunction. So you get the stiff ventricle that, this is oftentimes where you'll see in many instances, people will develop heart failure related to diastolic dysfunction. But let's talk about some of the changes that go on. I know we've alluded to some of them, but I think for many people, this will make it sound a bit more tangible.
Well, and let me just do a very quick overview of the different ways that estradiol directly affects the cardiovascular structures. So if we look at the arteries, so in order for an artery to be healthy, you have to have a healthy lining called the intima. Well, estradiol is the key on switch for an enzyme called endothelial nitric oxide synthase, which causes the production of nitric oxide, which is a gas, which we can't measure, but we can indirectly measure it by getting a blood test for ADMA. But nitric oxide is essential for vascular health. It also has many other benefits. It keeps platelets from clumping and clotting. It just maintains the health of, antioxidant status so you don't have inflammation, which damages everything. So it maintains vascular dilation, so you don't have constriction and hypertension. So nitric oxide is essential for vascular health And without estradiol, you will not have adequate nitric oxide production, and that's a huge problem. And then if we look at prostacyclines, so prostacyclines also maintain vascular health and keep platelets from clumping, and estradiol, once again, helps to create these essential prostacyclines. And the COX enzyme system, that's what's interfered with when you take an NSAID, a non-steroidal anti-inflammatory. And these COX enzymes come in different numbers. COX-1 is the one that keeps everything wonderful and happy and peaceful. COX-2 is what we would have that would be instituted if you have an inflammatory state. So it would be only triggered in inflammation. And that is the one that is supposed to be knocked down or blocked by the NSAIDs, but they actually block also to some degree COX-1, which is why they are associated. If you take an NSAID for at least 3 days, you have tripled your risk, especially as you're older, of having a heart attack or stroke. That's why long-term NSAIDs are really counterproductive. They're only good to take very short-term, like up to 3 days. But it turns out that estradiol maintains this whole enzyme system, the COX enzymes. It keeps you in that happy COX-1, except if you need to initiate an inflammatory response, because it's modulating that whole inflammatory on-off switch. And then if we look at like cholesterol, so cholesterol will only become problematic if it is oxidized, because if it's rancid, we call it oxidized LDL, then it is damaged tissue. Damaged tissue is recognized by the immune cells, and then they gobble it up because it's just damaged tissue. So cholesterol travels around the body in little envelopes called apolipoproteins. They're like if you wrote a check, you can't just drop it in the mailbox, you put it in an envelope. You can't drop cholesterol in the blood, it needs an envelope. So these are the apolipoproteins. So these are structures, and if the cholesterol gets oxidized or rancid, then it gets picked up, like gobbled up by the gobblers, the macrophages. And these macrophages are attracted to damaged tissue. If you also have damaged lining, the intima of the artery, they line up along the damaged artery inside. Here's the blood flowing, and there are cracks and fissures, and these immune cells carrying the oxidized cholesterol work their way in through the cracks and fissures into the actual wall of the artery, where they create even more inflammation, and through the signaling agents call it more inflammatory cells, creating basically a pile of junk in your artery wall. And if it's very inflammatory, it can erupt like a pimple popping, okay? And it pops and it goes into where the blood is flowing, and that little hole in the artery that was created by the rupture, a little clot forms on it, like a little scab, like if you ruptured a pimple. And if that breaks off, it travels downstream. It might as well be a rock at that point. It's not dissolved. It will be like a boulder, and it will block the artery somewhere. And that can trigger, if it's in the brain, a stroke. If it's in the heart, then it's a heart attack. If it's in the vascular system of the intestines, it's, ischemic bowel. So it's like blocking blood flow. So you're not going to have oxygen downstream. And in the heart, in women, that will trigger a heart attack. And what people die from a heart attack isn't the loss of oxygen to the muscle, killing the muscle. That comes later. That causes heart failure, like you mentioned, different types of heart failure. But initially, what happens is it triggers an arrhythmia. And after menopause, women's sort of system involving maintaining proper rhythm becomes much more fragile. And women will go into a fatal arrhythmia. And women die from first heart attacks dramatically higher than men. And it doesn't take as much for women to get triggered into a fatal arrhythmia. And it doesn't have to be like a big area of the heart that has oxygen obstructed, from the blood vessel. It could be a tiny little one, because it's not about loss of oxygen to large areas of the muscle of the heart. It's just that it triggers this arrhythmia through the electrical conduction system that can be fatal, totally fatal. And so it turns out that estradiol modulates an enzyme called peroxidase 1, also known as PON1, PON1, that prevents oxidation of cholesterol. That's why premenopausal women have a much lower rate of having plaque form, because they have this beautiful enzyme that helps to protect and protect the oxidations of cholesterol, so it doesn't happen. As well, cholesterol goes way up after menopause because the receptors on the liver called LDL receptors. So when you have old cholesterol, it comes back to the liver, and it's carried by these apolipoproteins called A1. So that's also known as reverse cholesterol. They come to the liver and they dock like a spaceship in a docking port, and then they go back into the liver, and then they either get recycled if needed, or they go out the bile duct, that's like the trash chute, into the intestine, where if you have binders, like lots of fiber in your diet, you can poop it out, okay? And that's why things that are very binding, like oatmeal, is like has the little heart from the American Heart Association, because it can bind cholesterol in the gut and then you poop it out. So in order for those receptors on the liver to take back the cholesterol, to get it out of the circulation, you need those receptors working. Well, it turns out estradiol maintains the functionality of the receptors on the liver to pull the cholesterol out of the blood. Without estradiol present, the cholesterol just accumulates in the blood, and then it's subjected to more oxidation potential, because of more inflammation that occurs after menopause in an absence of adequate estradiol. So you can see how this is like just is devastating. And then when you have problems, you get leaky gut because you don't have the right estrogen, and the right microbiome is related to hormones too. And then when you have inflammation in your gut, it affects your liver. So now you have inflammation in your liver. And after menopause, women have much higher rates of non-alcoholic fatty liver. And then you have a dysregulated liver that becomes a factory for glucose and triglycerides, which are fats, and cholesterol. All the liver is like a manufacturing center, and it's dysregulated when you have this impaired gut barrier and you have dysbiosis, or the wrong microbial population in the gut, which happens virtually to every woman as she goes into menopause. And then you have dysregulated liver, and then you have all this glucose and triglycerides, and you have all of this cholesterol being spewed out, and you can't even get it back out again. So you can see how this creates cardiometabolic total chaos. And I mentioned glucose regulation is controlled under estradiol. The glucose transport system of how the glucose from in the blood gets into the cells is under the control of estradiol. Without estradiol, the cells that need the glucose for energy can't even get them. And the mitochondria. Now, you mentioned about the heart. So the heart, I mentioned, of a woman who's pregnant has to be incredibly more energetic than that of a man. Well, the mitochondria of a woman's heart are special. They are able to produce more energy. But in order to do that, you need estradiol. In order to make energy and what's called the electron transport chain, you need to have estradiol. And then as a side effect of creating energy, you have a byproduct that's very toxic called superoxide, and it cannot get out of the mitochondria. It's like stuck in the mitochondria unless it's converted into hydrogen peroxide, which can diffuse out of the mitochondria, and in the cell be converted into harmless water. But that won't happen if you don't have an estradiol, because the enzyme system that turns superoxide, this toxic waste product caused by the production of energy, needs to have this enzyme to convert it, and that's called manganese superoxide dismutase. That enzyme requires estradiol to work. So if you don't have estradiol, you're not going to make energy, and what energy you do make, it creates this toxic waste product that you can't get converted to get it out of the mitochondria, so it kills the mitochondria. So now you have a problem of a poorly energetic heart. This is unique to women, and so it's ignored. And you can see it on an echocardiogram that the heart, when it's relaxing, like you mentioned, the diastolic phase. So the diastolic phase is when blood pressure is lower because the heart is filling, not pumping. So the pumping part is systolic, and that is reflected in the higher pressure and the blood pressure, like 120. And then when it's relaxing and refilling, that's the lower blood pressure, because there's nothing coming out of the heart at that time into the blood vessel. So the pressure goes down, and that would be like 120/80. So the diastolic part, the filling part, is unique to women in that the heart is, like you mentioned, stiffer because the mitochondria are not functioning properly. And so it's like you see it on, this is, a pretend version. So a normal heart would be pumping smoothly. And with diastolic dysfunction, it would be like stiffer and so the contraction part is fine. It's the opening when it's refilling that it's stiffer. And that is called mild diastolic dysfunction. And it can lead to a type of heart failure that's pretty unique to women. That's called heart failure with preserved ejection fraction. In other words, the heart is still pumping the blood out, but it's actually, so that's called preserved ejection fraction, but it's actually a dysfunctional heart, big time, because it is not relaxing properly. And that heart can kill you. Okay, that kind of heart failure can kill women. And heart failure is not a rare condition. And the cardiologists are not even looking for diastolic dysfunction like that. And even when they see it, they often discount it and say, oh, lots of women have that. Yeah, it's really bad. It's a sure sign that it's a energetic deficient heart. So these are huge things. And then the whole electrical conduction system that's controlled through the autonomic nervous system is regulated by estradiol. The neurotransmitters that cause heart rhythm is all controlled. It's a neurological kind of thing. It's all controlled through estradiol, which is why women are so prone to atrial fibrillation, and they're prone to having like supraventricular tachycardias, where they have palpitations and rapid heartbeats. So many women I see, they go to the cardiologist and they're just put on beta blockers, which are drugs that sort of slow the heart rate down, which can be helpful, but it's not addressing the root cause, which is that they're having conduction problems because their autonomic nervous system is dysregulated because they don't have enough estradiol. And so you can see how there's just such a wide array of issues that come into play. And it's like fascinating. I mean, and this is like not even covering everything because, it's complex and simple at the same time. On a molecular basis, it's really complex when you look at pathways and all of this and that. But when you just look at it, it's all designed for pregnancy success and reproductive success. And you need to have a strong, energetic heart. You need to have really healthy arteries. You need to be able to create an incredible placenta. You need to have the proper hormones to, keep you in the proper time zone, to have proper digestion, to, all these things need to be optimized for reproductive success. When you don't have reproduction any longer because, nature deems you too old and too risky and the reproductive capabilities go away, so too do these vital hormones. And then you're going to suffer in every organ system and hugely, I mean, just hugely in the cardiovascular system. And the best ultimate way is to start early in perimenopause, where, like you said, wherever you are, it's where you are. You just go and do the best you can wherever you are. I deem it you're never too late. And that's not the conventional approach. They say if you're out over 60 and you haven't been on hormones, or even if you have been and you reach 60, like now you're too old, that's illogical. That's like just like bizarre, actually, when you think about it. There's nothing that changes between 59 and 61. And all women go into menopause at different ages. So why would you think every woman is the same at 60 when some women went into menopause at 42 and some went in at 57? Like I'm just like an evidence-based person here. I'm looking at the data and the evidence, and there's no logical reason to think that estradiol would turn on you at any age or ever. That this confusion between the different estrogens and, the different receptors and getting all this mixed up, and the evil twin attacking the reputation of the good twin, it's just got to stop. It's just a vital life hormone, like a really vital life hormone. And when you don't have enough, it's like simple thinking. You just give it you try to give it at a level and a rhythm that mimics as reasonably close as we can. It's not the same. We're not giving you a new set of ovaries, but to be reasonably similar to the rhythms and levels that you would have when you're healthiest, like in your early 20s. It's just simple thinking.
What's interesting to me is, even as someone that has traditional both allopathic and functional integrative medicine training, I didn't realize until I went into menopause the changes that were happening. They may not have been visible on the outside, but when I was looking at labs with my functional integrative medicine physician, I was like, I cannot pretend that I'm not seeing changes in my lipids, in my insulin sensitivity, in a lot of different things that are going on. So for women that are listening that maybe perhaps are not on HRT yet, or have not started that discussion with their providers, understanding that you don't have to look unhealthy from the outside to have changes going on at a cellular level that are quite significant in this transitional period.
Absolutely. In fact, I have really changed my own approach. And over the last just very few years, I've really started supplementing hormones during the perimenopause, because the whole notion that menopause is crossing a finish line is so absurd. It's a process. And conventional medicine has looked at it as, well, you've reached that point, 12 consecutive months without any bleeding. We don't even know what that bleeding is. That's why I can't say without a period, because it could be just dysfunctional uterine bleeding from hormonal imbalances, not necessarily that you ovulated. So you go 12 months and there is no bleeding. And then suddenly you have that title, you are in menopause, and the rest of your life will be post-menopausal years. And that is so incorrect in the whole view of what's going on, because it's a process of ovarian aging or ovarian senescence. And during that time, there are hormonal fluctuations with a general trend downward. And we now know that long before that so-called last period and last end of reproductive life, that there are changes like loss of bone. There's changes in the ligaments in your joints. There's changes in sleep and mood and cognition, like word finding, like especially now, people can't remember names and such. And this is like very, very, very prevalent. There's changes in the gut microbiome. There's just loads of changes. There's changes in the vascular system. Plaque starts to develop, blood pressure starts to rise, and plaque, of course, is the instigator to heart attacks and strokes. So those risks really start to accelerate. And none of this is really taken into account because it's just viewed as aging as opposed to loss of these vital life hormones. So I look at it kind of like thyroid. No one waits till you have no thyroid function. You have like your thyroid gland has evaporated. No, when you have lower thyroid production, you get thyroid supplementation. Well, if you have reduced hormone production from your ovaries, you should have hormone supplementation. And when hormone production ceases in terms of no production of estradiol, the estrogen from the ovary, or progesterone, then you have hormone replacement. So before that, it's hormone supplementation. And this, I think, is really a new idea of viewing women's transitional health years. And this can make a total major change in the future of women's health and longevity, healthy longevity, not just surviving.
Well, and what's interesting to me is my training came about in the 90s and early 2000s. And when I finished my nurse practitioner program in 2001, and I drifted off into cardiology, this preceded the Women's Health Initiative, but I recall how many of my patients, all of their HRT, their hormone replacement therapy, was stopped because of the results that came from the WHI, which thankfully we now understand was, an improperly interpreted study, really not looking at a healthy population. And we've unpacked this on many other podcasts, so I don't want to go down that rabbit hole. But I think from my perspective, looking at HRT, looking at this transitional period in women's lives, helping them understand that the time to intervene is not to wait until you have your final menstrual cycle, as you stated. It's to really help women understand that if we are supplementing with hormones in that perimenopausal period, you probably will have less side effects. You probably will make a less dramatic transition. And what I see on a daily basis, across social media, is how many women are suffering in silence. They're being told, as an example, I was in a group the other day and they said, oh, my physician put me on oral contraceptives. That's to help me transition into menopause. And I know your feeling and mine are very similar on this, and helping them understand, well, that's not actually replacing your hormones. That is suppressing your natural production even further and actually introducing an endocrine disruptive chemical into your body. And so helping women be their own best advocates. And so that's why I love and appreciate your work so much, because you are the consummate women's health advocate and physician One thing that I think is really interesting when we're talking about estrogen as an immune modulator is talking about these different types of receptors, the ER alpha, the estrogen receptor alpha, the beta receptor. Can we start the conversation there? Because I think some of this physiology is actually quite interesting. And I know my listeners would probably agree with that as well.
Well, yes. And the first thing to just touch on is the word estrogen, because like you talk about estrogen receptors, but what is estrogen? Well, estrogen is not a hormone. It's a family of hormones. And there's basically in the adult female, human female, there's three. There's estradiol, which has a letter and a number. So it's E2, and that's the estrogen made by the ovaries during all the reproductive lifespan of a woman. There's E1, which is estrone, and that becomes the dominant estrogen, which is predominantly made in fat tissue, adipose tissue, in metabolically unhealthy women who have excessive amounts and a lot of inflammation, and also in postmenopausal women. And there's also a balance between estradiol and estrone in reproductive aged women that the body directs so that it's done appropriately. And then there's E3, which is estriol, which is the dominant estrogen produced by the placenta during pregnancy, which also exists in reproductive women in smaller amounts, and it's a derivative of estradiol. So there are these three. And then there's another one, which we won't even go into, E4, which is a fetal estrogen, although just to know that estradiol, and that one is now being looked at as to be marketed in products for adults, adult females, which makes no sense. Just because you can make it doesn't mean that you should be using a fetal estrogen. It's like so absurd, even the thought of it. And then, of course, they use the word estrogen to apply to a whole host of chemical agents that exist either in other animals like horses or coming from manufactured, products from factories that are really essentially endocrine disruptors, like you mentioned. So they bind in various ways to estrogen receptors. They interfere with the production, distribution, degradation, distribution, and so on of real human produced estrogens. And they call them estrogens, but they're really endocrine disruptors, these chemicals. So it's just very weird how that word estrogen is thrown around. But if we look at estradiol, E2, the dominant estrogen of the reproductive aged woman made by the ovaries, it has a balanced effect on the different estrogen receptors. So now we know that much of the action of hormones, not 100%, but most of the action of hormones occurs through the binding of the hormone to its receptor. And sometimes people think of it as like a lock and a key, and the receptor is the lock and the key is the hormone, but it would be more like a like a a Jim Carrey mouth, where it has like a shapeshifter, because, it's not fixed. The receptor isn't in a fixed shape like a lock. It can actually open and close more like a mouth, and it can be open a little bit. So I think of a receptor also like a baby's mouth. If the baby doesn't like that food you're trying to get into him or her, it'll just clench that little mouth closed. And if you try to get it in, that little tongue will just push it right out. So, receptors aren't always so receptive. It depends on different things that are going on in the body. And these receptors for estrogen, estradiol in particular, they have a different propensity, a different predominance in different organs. So, for example, in the brain, and we're still learning about this, there's predominantly the beta that's in the cerebellum and the cerebral cortex. So it's more about, thinking. But in the hypothalamus, which regulates a lot of metabolic and reproductive processes, that's more alpha. And in arteries, it's more alpha. In the gut, it's more beta. And on immune cells, it's a blend, and they're always a blend. It's never 100% one or the other. So in immune cells, the innate immune cells, so they are like I call them like the first responders or the attack animals. They're like landmines that are set up, and they indiscriminately want to kill any invader. They don't think about, the type. They just say invader, invader, kill, kill. And that group is predominantly, not exclusively, alpha. And then the other immune cells that make antibodies, the B lymphocytes, they are predominantly beta, but not altogether. And this is also an evolving science. And then there are different types of receptors on the membranes, on the surface of different types of cells. But we now know that the other types, the alpha and the beta, which we thought were only nuclear receptors, so they only worked in the nucleus of the cell, they also have sites on the cell membrane as well, and they interact with one another. So if you have a great deal of beta activation on the receptors, the beta receptors, it actually downregulates the alpha receptors. And so all of this is very, very intricate, very complicated, and it relies on the specific type of the estrogen. So the estradiol has the balance effect on all the receptors. Estrone, E1, is predominantly alpha, and estriol is predominantly beta. And of course, the immune system has to be amazingly modified during pregnancy to allow a fetus, an alien, to actually exist in the mother and not be destroyed by the immune system saying, attacking, we're going to attack this alien. And of course, that does unfortunately happen. And that's one of the causes that some women have recurrent miscarriages. So the immune system is very dramatically modulated by the different estrogens that are present within the pregnant woman. And the thing that is so confusing to so many people is that when you take certain types of hormones, like for menopausal replacement, and you take them orally, even if it's estradiol, but you swallow it, it goes through the digestive tract and the liver, and it's converted predominantly into estrone. So it goes into the body, into the bloodstream as a different form of estrogen than what you swallowed. And it has a different effect because estrone is predominantly going to affect the alpha receptor. And when you use the conjugated equine estrogens that you mentioned from the Women's Health Initiative, that particular group of estrogens, which includes these equine with horse estrogens that don't even exist, and these are previously conjugated. They've gone through the liver so that the horse can now put them out through the urine to get rid of them. The horse doesn't even want them anymore. And they have a lot of alien types of estrogens that would never exist in a human female. And now we know, because inflammation is about blood clotting. That's like a really important facet to understand about the immune response called inflammation. So when you swallow the pill, the conjugated equine estrogen that was under the brand name Premarin that was used in the Women's Health Initiative, it increases the risk of blood clots fourfold. I mean, so that is now going to create problems if you have a fourfold increase of blood clotting, and then you're giving it to older women who innately have a higher risk because they're older and also they've been estrogen deficient for many years. And when you swallow estradiol, that increases the risk of blood clotting about twofold. And when you use transdermal estradiol, it not only doesn't increase the risk, and I can't prove this, but if you look at the mechanisms that occur in the body with estradiol, the one that the ovaries make that you're giving through the skin, whether through a gel, a patch, a cream, when you use that type of estrogen, I personally believe, I can't prove it yet, but it lowers your risk of blood clotting, not increasing, because so many people are so mixed up. That's why bringing up, estrogen receptors and different types of estrogen, and they have different effects. So another analogy I use now is fats. So if you said fat is evil, well, we know that I had to defend fat. You probably did too for a very long time, because fat is a group of compounds. And there's trans fat, the evil fat that was manufactured, which we know, that's what kept Twinkies fresh, for 100 years. It would not go rancid. It would also destroy your body. But, there's monounsaturated fats, there's polyunsaturated, there's saturated fats. They have different effects in the body. There are different structures. And so you can't say fats do this, fats do that. You've got to say, what kind of fat? The same thing with estrogens. Well, what type of estrogen are you even talking about? Is it a human estrogen? Is it a manufactured estrogen that, isn't ever found in a human female naturally, and so on? So by looking at the effects of the different types of estrogen on immune cells and the different types of receptors that are activated, we can really start to decipher and understand the global effects throughout the body of estrogens and the one made by the ovary, estradiol.
Well, and I think you bring up so many good points. Clearly, it is more complicated than we realize. Number two, understanding that these systemic effects, different types of estrogens have different effects within the body. And very interesting about Premarin, that's the pregnant mare's urine. And I think for many, many years, there were a lot of prescribers that were using that, understanding you get a greater increase in DVTs or deep vein thrombosis, probably pulmonary emboli as well, but with the more natural estradiol or transdermal estrogens, you're going to have less likely exposure to those kinds of issues. Can we speak a little bit about mast cells and histamine and hives? Because a lot of women that I'm seeing in this transitional period of time, and this loops into the immune system discussion, why do we see so many women at this stage of life that suddenly start getting activation of a histamine response? Because in this presence of probably, fluctuating higher levels of estradiol in their bodies in this perimenopausal into menopausal transition. I have women that will tell me, I've never had hives in my life. And now if I eat too many of the wrong types of foods, all of a sudden I'll break out in a systemic, head to toe hives. And why is this happening? I know there's this interrelationship with mast cell degranulation and histamine response and estrogen as well.
Yes, and like everything, it's on multi layers of how this is happening. So mast cells are part of the innate immune cell group. So what we call the first responders. And in fact, mast cells are the ultimate first responders. So mast cells are located along interfaces between the outside world and the inner body. So you see mast cells, very heavily in the skin, because that's obviously an interface between the outside world and the inner body. But, also in like sinuses, in nasal passages, in the bronchial tree. You even see it in like the so-called blood-brain barrier. So mast cells are very, very key as first responders. They are the only immune cell of the body that has prepackaged all kinds of stuff like tumor necrosis factor alpha, these inflammatory cytokines. They have chemokines that call in the troops, the other immune cells, to come to the scene of the injury or the infection. It also has prepackaged histamine, like you said. So it has a whole bunch of different things. It also has receptors on it. They call toll-like receptors to bind with everything. Parasites, every kind of bacteria, every kind of virus, all kinds of things. So the mast cells are the ultimate first responder. They are there like landmines to protect the body, and they are appropriately activated, if you have one of two things: damage, which could also include like dying cells, old cells, and injury, like a burn or a trauma of any kind to the body. That will activate mast cells. And that is to protect you, so that if you have an invading pathogen, like a virus or a bacteria trying to get in, this is like, okay, you're going to like throw everything at this invading pathogen. You're going to create an inflammatory response. You're going to call in the other immune cells to come to the scene. You're going to try to create just a lot of, like putting out enzymes and histamine, which is going to create a lot of different change of blood flow to the area and so on. So we know that these mast cells are going to save your life in the proper scenario. And as well, if you have other issues that activate the mast cells inappropriately, then you get these abnormal responses, like you have allergic rhinitis, for example. You can have asthma responses and so on. So when you have a dysregulation of the immune system, then you can have these abnormal activation of mast cells. Sometimes when people do it all the time, they call it mast cell activation syndrome. And since mast cells contain all of these pro-inflammatory products, which includes the histamine, it can really play havoc through the body. Now, as well as being activated by estrogen, and predominantly the alpha receptor. It also interconnects with the autonomic nervous system, which is the neurological system of the body, which controls everything that we don't think about, including things like vasodilation or constriction of blood vessels, sweating, temperature of skin, your pulse, so your blood pressure, all secretion of digestive enzymes, motility of the gut, all the things we don't think about. And that includes a lot of effects on the immune system, including mast cells. Well, it turns out that not only does estradiol, like I call it modulate, like regulate all of the immune cells. So it turns on. This is like a really important concept. So estradiol is the on and the off switch to the inflammatory response. So inflammation is essential to save your life. Like we said, if you have an invading pathogen, bacteria, virus, fungi, anything, or you have trauma to your body, the pro-inflammatory response can save your life. So we definitely want to have that. And estradiol turns that on appropriately, because there are receptors in every one of the immune cells of the body, every single one. So it turns on the switch to create inflammation when you need it, but it also turns on the off switch. And what happens when you turn on the off switch? That promotes healing and resolution, creates growth factors so that you can heal injured tissue, replace tissue. It creates growth factors for new blood vessels to provide blood supply. It also causes platelets when you need them, not only to create growth factors, but to also wall off infections. That's how you get abscess cavities that can save a person's life. It walls off the infection. So it does all these things to promote healing, but it also creates the inflammatory response in an appropriate way. Well, when you're in a perimenopausal state, all of these things are in a fluctuating status, and the hormones often go up and down inappropriately. So the signals that are coming to the immune cells can become sort of jumbled. And on top of that, I mentioned the autonomic nervous system. So the autonomic nervous system is actually also modulated by estradiol. So there's two arms of the autonomic nervous system: the parasympathetic, which is what should be the standard baseline status, which is like calm, you have proper gut function, motility, your skin is warm, everything is right. Your immune cells are surveilling, but quiescent. They're not activated. They're just kind of like, they're guards. They're watching out for you, and everything is quiet. But when you don't have enough estrogen, the autonomic nervous system becomes quite dysregulated, and the parasympathetic gets sort of like taken over by the sympathetic, which is the stress response. And that changes everything. That activates your immune system, and often inappropriately. Like if you're feeling all stressed out and tense, but there's no invading pathogen, you're not really in danger, but you're acting in your body as if there is. And the neurotransmitters for both of those types, the parasympathetic and the sympathetic, are controlled in large measure by estradiol. So the one that activates the sympathetic is norepinephrine and epinephrine. And everyone's heard of an EpiPen. So if you inject someone that needs to have, is having an anaphylactic reaction, from an allergic response, and you inject them with an EpiPen, it actually dilates their bronchial tree so they breathe. And that's part of the stress response, so that if you're running for your life, you get more oxygen into your lungs. But it changes everything as well throughout the body in very different ways. And your heart beats faster, you change blood flow to your skin, your immune system becomes hyper vigilant and upregulated because you may be injured because you're in a stress situation. And the parasympathetic is controlled by a different type of neurotransmitter called acetylcholine. And that is actually in the brain, helps to create memories. That's another problem that we have when we lose our proper production of estradiol. But in the autonomic nervous system, it keeps you in that calm sort of state, and it sort of keeps those mast cells from going wild. Okay, so you have the problem with the fluctuating estrogen, you have the autonomic nervous system becoming dysregulated, you have the receptors on the actual mast cells becoming on and off switch and so on. And in addition, you have, as you transfer your hormone production and it changes, your gut microbiome changes. And now we know that about 70, 80+% of the gut is surrounded by the immune system called the GALT, the gut-associated lymphoid tissue. So that's the majority of the immune system of the entire body. And of course, they contain many mast cells. And of course, there are many drugs that are trying to modulate mast cells, like people take Pepcid, that is sort of a modulator of mast cells, because this can affect your digestive tract in all kinds of ways. So what happens is when you now have an altered gut microbiome, you have what is called impaired gut barrier, because you don't have the right gut microbes to create this protective mucus coating, and then the lining cells of the gut become inflamed, and the little fibers that hold them in close proximity, they start to degrade, and the cells start to separate, like drift apart, and then toxins and bad bacteria and such in the gut can actually get into the body proper, where the immune system resides, and it activates the immune system. That's what we call leaky gut. Now, it turns out that when you don't have enough estradiol, you lower the threshold to activating the inflammatory response. So the same amount of this, like toxic stuff we call like endotoxins or lipopolysaccharides that get into the body through the gut, it takes less to activate the immune system to go into a pro-inflammatory state. So it's like the total perfect storm that's happening in women. You're having this dysregulation of your autonomic nervous system. You're having, altered actual receptor function on the immune cells themselves. You're having this dysbiotic gut microbial population and leaky gut, and you have lower sensitivity of the immune cells so that they become sort of like, we'll say, lower resistance to inflammatory stimuli. So they react with a greater response of inflammation to a lower degree of stimulation. So it's the perfect storm for having immune system dysregulation. And in many women, it will manifest as well, like you mentioned, with hives. And we know that the brain is the ultimate sort of regulator of a lot of functions in the body. And women, as they transition into menopause, have more anxiety, poorer sleep, a lower threshold to becoming very stressed. And the brain itself, through the autonomic nervous system, can trigger hives. Many people have hives and they're not even perimenopausal, especially women, because women are more sensitive to all of these things, and they can have an emotional response and they break out in hives, right? So, or they feel emotional and their face turns all red. That's part of this response system. And so it's really a problem, and there's been so little research on it. The traditional approach, of course, is to give antihistamines, and that can help for a lot of people. So I'm not against giving pharmaceuticals when you need to. And of course, there's also, herbal things that can help stabilize mast cells as well, like quercetin and stinging nettle and so on. So there's a variety of other natural products that can help stabilize mast cells. But the ultimate stabilizer is proper levels of estradiol.
Well, and I think that connection is not made. I think that there's so much focus on, appropriately so, brain health, heart health, bone health. But when I started to understand the gut microbiome and the role of the estrobolome and all of these factors, I realized, why aren't we talking enough about this? Because women are wondering why they're suddenly more susceptible to parasitic infections, or they're having quite a bit of dysbiosis, whether that's done by, stool testing. And it makes so much sense about how there's this protective role of estradiol in terms of, down to a cellular level in the gut microbiome and immune function as a whole. Now, when we talk about how estrogen impacts these endotoxins, so lipopolysaccharides, and for anyone that's listening, I know that seems kind of intangible, but I'll provide an example. Everyone knows I like to travel. I went to Morocco and picked up the worst food poisoning I'd ever had.
and very clear that I had been impacted by this lipopolysaccharide, this endotoxin, which I think kind of preceded me developing a ruptured appendix. But I think for so many people, understanding the role of inflammation and these changes in estradiol levels that are impacting how well we can fight off infections, I think that's certainly important. But can we speak a little bit to the estrobolome or the estrobiome, depending on the individual that's talking about it, understanding how our body in the setting of estrogen is able to properly or improperly break down and deconjugate estrogen so that we can get rid of what does not belong. I know that seems to be a huge issue for many women as well. They get this recirculation of estrogen. The liver is designed to help break down these estrogen compounds. And in some people, whether it's through genetics like poor methylation or other, SNPs or contribute genetic propensities that make it a little harder for them. But I think the estrobolome is one area of the gut that I find really fascinating. And I think for a lot of people, they're probably not as familiarized with it. It seems very strange. It's a funny name. And I don't think there's enough focus on the interrelationship between estrogen and the gut microbiome.
Well, absolutely. And I think the first we'll say, primary area that needs to be just acknowledged, because it isn't, is that estradiol is the hormone of life. And that's really key, because it's really thought of as just a reproductive, not that that's little, but reproductive related hormone, like it gives you menstrual periods and it's involved in getting pregnant, but that's kind of it. But, it is so not just it, because the prime directive of life, and I figured this out many years ago as I delivered thousands of babies as an OB-GYN, it is the creation of new life. Now, that's what the whole female body is designed to do successfully. Now, we as humans, and I think rightfully so, we want to determine when and if we have babies. But there's no other species on this planet that is thinking, hey, this is a bad year, let's not mate. That doesn't happen in nature, right? Only in humans do we say, let's not have kids, let's do something about it. But once you accept that the prime directive of life, of all evolutionary life, is the creation of new life, then you have to acknowledge that in order to be successful with pregnancy, and this is actually a growing problem now, you have to have a healthy body. And in all aspects, you have to have a healthy body: the brain, the entire neurological system, the musculoskeletal system, the gastrointestinal, the cardiovascular, the genital urinary, every single system has to be functioning optimally and together. You have to have everything working in the same time zone. That's your circadian rhythm, which is modulated also by estradiol. So once you realize that every organ system requires estradiol to function properly, then it helps you to understand what's going on in the gut. Why do we have this special group of microbial life forms in the gut designed to address detoxification, or what I prefer is the word biotransformation, because it's not that estrogen is toxic, that word kind of gives you the wrong idea. It's really biotransformation, because you're transforming products in the body from one state to another for the ability to get it out of the body, right? So you can transform it so that it becomes either, water soluble, so it can go out through the kidney and the urine, or it's modified so that it can go down, I call it the trash chute, the bile duct, into the intestine, and then you can poop it out, right? So because everything gets old and you don't have the same hormones that you had when you were 14, it's, everything changes. So because estradiol is so critical to the health of the female body, and we won't go into men. They really should love estradiol too, because they make tons of it. They transform their testosterone into estradiol. All estradiol comes from testosterone, every drop of it, no exceptions. And men make tons of estradiol, but they make it in the specific organs themselves. It's not circulating. We call that paracrine. So estradiol is essential for males and females, but just focusing on females. There's a time in a woman's life that when we talk about reproduction, when women stop making estradiol. Now, I'm not talking about menopause, although that can be useful, because evolution wasn't designed to deal with menopause. That's sort of like the afterthought, that women can live quite a number of years in a post-menopausal state. But that's really not nature's primary concern. Okay, so it's really what about during the reproductive life? Because that's really essential if you're going to have multiple babies, because human females, to be successful in terms of reproducing the species, they have to have more than one, because that's not enough. So that, and you're going to have some unfortunate, issues with child mortality and so on. So nature wanted human females to have multiple pregnancies and bear multiple children and raise them. So what happens in a woman's life if she has a baby, and then after the baby is born, and the placenta, which is the primary endocrine organ of pregnancy, making all of that estriol and also estradiol, and it also makes testosterone, which is a precursor for all of the estrogen. Then what happens is the placenta is delivered. There, oh boy, no more placenta, no more hormones coming from that organ. And the ovaries go into a quiet state. So you make prolactin, okay, and that helps the woman so that she can lactate. She makes breast milk, and that acts as sort of a natural contraceptive, and it shuts down the ovaries. In fact, this is a problem in endocrinology. If a woman has a prolactinoma in her pituitary gland, she has this little benign tumor, but it's making too much prolactin. That's the source of it. It will shut down her periods. So that's what prolactin does. And nature makes it intentionally. So you have this little built-in birth control. How great is that? Nature doesn't want a woman who just had a baby to immediately become pregnant again, right? That would not be very useful. So prolactin shuts down the ovaries. Now the ovaries aren't making any estradiol, but estradiol is essential for every organ system in the body. What's going to happen? What are we going to do? Well, it turns out that the adrenal gland is still making its androgens. And androgens can be converted through this enzyme called aromatase, which exists in many organs, including in the gut. There are these special areas that are called Peyer's patches that actually can make estradiol from precursors that come from the adrenal gland. Okay, so you can actually make some, but very small amounts, okay? And you make it in the organs themselves. So it's not circulating. So if you did a blood level, it would be very low, but it's made in the organs themselves. So you do that's how women, when they're nursing their babies, they still have some estrogen in their body because they're making it from these androgens that come from the adrenal gland. Well, it's so important to have estradiol in the body, but not to have fertility. So the ovaries have to be shut down so you're not ovulating. And so that's all quiet. So nature made this special group of bacteria in the gut that can recycle estrogen that's made in these other organs, like in the gut itself. And that's like, I'm never even sure how to totally pronounce it, estrobolome, but in any case, so that's how I say it, which may be incorrect, but the estrobolome. So it's just special bacteria that actually work on the estrogens to recycle them. So this, in a healthy woman, this is nature's best gift, to give back estradiol into the circulation. But what happens now? Well, we live in this crazy world where people are eating weirdo food, the standard American diet, and without realizing it, they've done everything possible to destroy their good gut microbiome. So we have tortured them, we've poisoned them, we've starved them. So the poor estrobolome, the bacterial group that is designed to help properly recycle estrogen so that women who are in the postpartum time have enough estrogen to maintain proper function of their organs. Now things are all messed up in so many ways. So you end up with the wrong microbial population and the wrong ratios, and suddenly you can have poor metabolic transformation. This biotransformation isn't happening correctly at any stage. So the transformation of estrogens so that it can be removed from the body is a multi-stage process. And it includes the intestinal tract and different stages in the liver. And then the final stage is back into the colon and involving these special microbes that are addressing estrogen types of, issues in terms of eliminating estrogen. So when everything is wrong, which is what's happening now, and then not to mention it, but that unfortunately so many people are exposed to antibiotics, which kill off a lot of the what we call the commensals, the good guys, right? And then nature will never allow a vacuum, so bad dudes, replace the good guys, right? So you have the wrong microbiome population. So now suddenly you may inappropriately create, recycled estrogen when you don't want it, so you get, it's like too much of a good thing. You can have always too much of a good thing or too little of a good thing. Everything should be just the right amount at just the right time. So when you have the wrong microbiome in the gut, you also probably have messed up problems going on in the liver and in the small intestine as well. So many people have small intestinal bacterial overgrowth. So phase 2 detoxification isn't going to happen properly either. And you need to have some degree of fasting, your expertise as well, in order to fasting in different forms can also upregulate the phase 2 detoxification pathways, which are really sort of under-recognized and underappreciated. So the bottom line is that we often have an overpopulation of the wrong microbes that put out enzymes like beta-glucuronidase, and they end up creating too much recycled estrogens or the wrong types of recycled estrogens. Because remember, estrogen is a family of hormones, and estrogen metabolites, like these downstream products of biodegradation of estrogens, can have good or bad effects. Like there are some that are metabolites of estrogen that are so critical. There are even receptors, for example, in the heart to certain types of estrogen metabolites because they help create energy in the heart. So they're so important. But then there are other types that can actually be pro-carcinogens. They can maybe even promote breast cancer. There's a link there. So it's so important to have a healthy gut microbiome, and also to put the whole area of the estrobolome in perspective, that it's not abnormal. We want it. It's actually life-saving, and I think critical during the time of life postpartum when women's ovaries are not working, so that you get the adequate amounts of estrogen made and recycled. But when things go awry, as we know, then everything, goes down the tubes, and then you have, and that's unfortunately how estrogen often gets a bad rap, So the problem isn't estrogen. The problem is the gut microbiome and the diet and the stress and all the other lifestyle issues that come into play that alter the gut microbiome and make it dysbiotic or abnormal. So it's a very crucial part of being a healthy woman, is having this healthy group of specialized microbes that address estrogen. But it's so important to keep it healthy. And what's interesting is in menopausal women, and I don't think this was really nature's intent, because I don't think nature had a grand plan for menopausal women, because there's no evolution in the menopause. So I don't know how a grand plan could exist, but women can utilize these specialized microbes for recycling estrogen appropriately. And there's actually some published data that when women have a healthy gut microbiome, they can get some naturally produced through the recycling process of estradiol that actually has been shown to help maintain vaginal health. So there's this group of women that somehow, even as they go through menopause, they don't seem to have a lot of problems. Like they don't have vaginal dryness. That's actually a very small minority. They don't have night sweats. They don't have hot flashes. Like, what's so special about them? How are they doing this, And it may be because they're the ones who lived the great lifestyle. They have maybe lucky genes too, and they maintain this healthy gut microbial population that they are able to actually use these specialized microbes, and they're recycling in a very good way. Their estradiol is coming back, and it's actually helping to maintain a healthy body in the menopausal years without even taking supplemental estrogen.
That's really interesting. And I would imagine individuals that are listening to the podcast, they're probably wondering, what are some of the common signs? And we've touched on some of these, but what are some of the common signs that the gut microbiome is not optimized in this middle-aged years, in perimenopause and menopause? What are some of the more common things that you're seeing clinically with your patients?
Well, the most obvious one is change in bowel habits. So I mentioned the autonomic nervous system is controlled through estrogens, estradiol in particular. And what happens is there's this huge group of neurons. That's why someone coined, the gut as the second brain, because the neurons in the gut are so complex. There's so many of them. There's a lot of similarities to the brain in terms of they have the embedded microglia, those are the specialized immune cells, and it regulates the gut motility. Okay, so after menopause, there's often a greater, and women tend towards having gut problems the most anyway, because of their sensitivity. Women are just more sensitive. Their autonomic nervous system is much more reactive, like it's like sensitive to emotions, much more so than in men. That's why women have like 80% of irritable bowel syndrome occur in women. Okay, so it turns out that a lot of women after menopause have a lot of gut problems in terms of acid reflux. The incidence of gastroesophageal reflux, GERD, it is higher. GERD is higher in men up until women go through menopause. And then women have a higher incidence of GERD after menopause. Women have more gut problems with, constipation and so on. They'll have change in their stool consistency and so on. So look at changes in gut function, both upper, like with heartburn and reflux disease, and also with having regular bowel movements and the consistency of the stool. So that is really common. Those are the ways to really, really tell. It's so important to have at least one bowel movement a day. More is even better. And, there's all these rating systems for a stool, but the most important thing is that you don't have little rabbit pellets coming out of you. That is not good. And what do we know now? We didn't know this in the past. What is the biggest component of stool? It's bacteria. Okay, so if you have hardly any stool and they're very tiny and they're very hard, then you don't have the right microbes. I can tell you that. That's like the poor man's way of getting a good gut microbiome test. Okay, just look, if there's very little stool, then you don't have a lot of good microbes, because it turns out that the microbial population, the bacteria, actually make up the bulk of what stool is. Okay, it's not just leftover food. It's really microbes coming out of you, the old microbes. So having proper motility, having good, like these like big sort of sausage shaped type poops coming out of you regularly, because elimination is not like an optional function of health, right? You've got to be able to have that happen properly. And of course, women, unfortunately, after menopause have very high rates of developing non-alcoholic fatty liver disease. And of course, the liver is the powerhouse of detoxification. And of course, it's a mega factory, in terms of what it makes and different kinds of proteins and so on. So, having a healthy gut is going to translate into a healthy liver and vice versa. So when you have an abnormal gut microbiome, it creates a lot of inflammation. And there's this, what they call the enterohepatic circulation. The connection between the gut and the liver is very, very complicated and very important. So when you have the wrong gut microbiome, that will impact directly on the liver's health. So I recommend that most women, if they are like overweight, if they're not feeling healthy, things are just not right as they're transitioning to menopause, get an ultrasound of your liver. That's the only way to actually, at this point, to diagnose this non-alcoholic fatty liver status. And that is not going to be found just by having abnormal liver enzymes. That's a late stage finding. So you've got to know this. And that will be another very, very easily detectable way of knowing that your gut microbiome is off, because they go together hand in hand, health or poor health, the liver and the gut. So these are really important. The other ways that you can know is that the gut itself is also an endocrine organ. Okay, so there's been a whole lot of emphasis on this little gut hormone GLP-1, right? And that's with all the weight loss drugs that are coming out, like Wegovy and Mounjaro, which also has GIP, another different little hormone type product. Well, it turns out, most people don't know this, but estrogen, estradiol in particular, is very key to the production of this little hormone that is very key to regulating metabolic functions and appetite regulation and so on. So after, when women are transitioning to menopause, if they notice that they have dysregulation of their appetite, like they have the night munchies, they start binging, all of these things can actually be treated. In fact, there's published articles showing that binge eating disorder can be treated with an estrogen patch, because low estrogen is key to regulating, or dysregulation of proper appetite and fat burning. The little peptides like ADP kinase, AMP kinase rather, these are really regulated by estrogen. So without adequate estrogen, your appetite becomes dysregulated, you will gain weight, particularly visceral fat, and you're going to just not know when you should eat. Like, you don't know, am I hungry? Am I not hungry? I could eat at any time. You may start binging. That's a clear-cut also indicator that you have abnormal gut microbiome. And that's why one of the other things that can help to increase your own natural production of GLP-1 is fiber, because fiber nurtures the gut microbiome as well. And also, though I call it the magic of food, the phytoestrogens. So many of the so-called superfoods are actually containing phytoestrogens. They're not estrogens, but they're plant-based components, molecules that actually combine to estrogen receptors, creating a very beneficial effect. And these have been shown to help restore gut microbiome. They help restore appetite, and they do a lot of amazing things. There's studies that even show they can suppress night sweats and hot flashes, and they're not real estrogens. They're plant-based, these amazing products. I call it the magic of plants, but they're not, replacing giving estrogen in menopause. But no matter how hard we try, we're not going to replace hormones like by giving a new set of 21-year-old ovaries. So we need all the help we can get, to restore the gut microbiome, to maintain a healthy immune system so that we don't get cancer. Like when people talk about like cancer, who has the most cancer? Older women, postmenopausal women, not healthy women who have beautiful regular cycles. When they get cancer, which is horrible, it's usually because of chemical endocrine disruptors, these like toxic chemicals that we're unfortunately bathed in our societies now that interfere with proper hormone functioning. So it's really essential that we stop, putting the blame on the blameless, that estrogen is the cause of all of these things. It's loss of estrogen and then loss of our healthy gut microbiome and loss of control of our immune system, because it's chronic inflammation, which underlies every bad thing in the body, including cancer, cardiovascular disease, dementia, osteoporosis, osteoarthritis. These are all inflammatory processes. And once it's recognized, and hopefully everyone out there now will understand this, that estradiol is actually the regulator of the immune system. It turns on and it turns off inflammation. When you don't have enough estradiol, you go into a chronic state of low-grade inflammation. And that's what happens in postmenopausal women. They have the abnormal gut microbiome, their immune cells are dysregulated, and they go into this pro-inflammatory state. And different estrogens have different effects. So it turns out, you can think of it this way, it's a little simplistic, but estrone turns on the innate immune cells. It turns on inflammation, okay? And estriol turns off the innate immune cells through the beta, okay? And estradiol takes care of everything. It turns it on when it should, it turns it off when it should. So after menopause, when you have a lot of inflammation, what does that inflammation do? It actually upregulates the enzyme aromatase that converts androgens into estrogens. Well, the dominant estrogen that's made is estrone, and it's made from the adrenal androgens. And it turns out when you have a lot of chronic inflammation, it actually blocks the action of the enzyme that can interconvert between estrone and estradiol. So you make estrone and then you get stuck as estrone. So you get stuck with the on switch for inflammation. I mean, that's really important. So it's not estradiol from the ovary. It's not estradiol that we would give women through the skin as a postmenopausal hormone therapy. It's estrone made from pro-inflammatory fat due to a pro-inflammatory state of the body with the upregulation of this enzyme aromatase that's causing the production of estrone. Now, why would that be? Like, why is it that inflammation would turn on this enzyme? Well, once again, it goes back to reproductive success and survival of the species. So once again, in a postpartum woman who is breastfeeding, she is not making. Can you hear that? Is that okay?
No, I can't hear it.
Somebody's running a lawnmower. Okay. So, thanks. Sorry. So in a postpartum woman, she is not making her own estrogen from her ovaries. So what happens? Well, what if she gets a breast infection? She's breastfeeding. Well, estrogen turns on and turns off the whole inflammatory process so that you can deal with invading pathogens like in the breast. So the breast has a lot of fat tissue. And that's not an accident. So the fat tissue in breast can actually make its own estrogen locally in the breast to control the inflammatory response of the breast to an invading pathogen. So that if you get a breast infection in a breastfeeding mom, you have the capability of modulating or regulating the immune system in the breast to actually properly fight off that infection. And so, but that's a temporary thing. And when the infection is gone, then what happens is, the production of estrogen in the breast goes down. Well, what about in a postpartum, what about in a postmenopausal woman? Well, her whole body is in a pro-inflammatory state, including her breast. So the fat in breast tissue has the ability to make estrogen at every stage of life, including in the postmenopausal women. So now you have the perfect storm for creating breast cancer. You have an inflammatory environment, and inflammation causes potential DNA instability and DNA breakage and the production of cancer cells. Now you have fat tissue in the breast that's in an inflamed environment, and the enzyme aromatase is upregulated. So now the breast tissue in a postmenopausal woman is making estrone. Okay, but it can't get converted into the proper estradiol because of inflammation downregulating the conversion enzyme. So now you have the perfect storm. Like I said, you have inflammation, you have production of estrone, and estrone works on only the alpha receptor. Well, it turns out that breast cancer, when it has estrogen receptor positivity, it's always the alpha receptor. So here you have it. You have inflammation promoting the production of cancer through DNA instability and breakage. And now you have estrone. And estrone, like all estrogens, can promote growth factors. And so now it's actually promoting the growth of this cancer, which has estrogen receptor positive alpha receptors. But why is this even happening? Is this because the woman was getting estradiol as a replacement hormone in menopause? Absolutely not. It's most likely because she wasn't, because without estradiol, you get this pro-inflammatory state. You have the dysbiotic gut microbiome, the leaky gut, the dysregulation of the immune cells. So they become more hyperreactive, more pro-inflammatory, and you can't turn the inflammation process off because you don't have the estradiol. So there's really a logical reason why postmenopausal women, and particularly women who are have obesity, because we know that the most high risk factor for postmenopausal breast cancer is weight gain, actually. So and of course, weight gain is associated with more pro-inflammatory status. So it's inflammation that's out of control in the breast that's causing the production of damaged tissue and the pro-inflammatory production of estrone that then feeds and nurtures this cancer that has nothing to do with estradiol. And when you get estradiol into a woman right at the get-go during the perimenopausal years, you can hopefully, and we need more data, but when from a scientific perspective, it seems obvious to me that you will maintain the environment of a healthy premenopausal woman. If you can maintain that, then you won't get into this chronic state of systemic inflammation, and particularly in the breast tissue. You're not going to have all this estrone produced, which is pro-inflammatory. You're going to have the proper estradiol, which is the balance effect on the immune system. So you'll be able to reduce your incidence of cancer. Remember, cancers increase with aging. Like colon cancer is much more common in postmenopausal women than premenopausal women, just as is breast cancer and other cancers, like pancreatic cancer, brain cancer, liver cancer. All of these are much more common in postmenopausal women because the immune system is now not regulated properly to do its job optimally. And also like sepsis, women who are premenopausal have much higher success rates in survival with sepsis, like infection, systemic injuries from bacteria, and even like brain trauma. Brain trauma is much better controlled in premenopausal women than in postmenopausal women, because estradiol is key to regulating, the healing process in the brain as well. So that's very key. So estradiol is the modulator of the immune system. It keeps everything humming just right. Without it, everything goes into this disarray, and you end up with things like, these cancers, and you get overproduction of estrone from this pro-inflammatory adipose tissue. But once again, because people don't distinguish this estrogen from that estrogen and the underlying mechanisms, it all gets jumbled together, and then estrogen becomes the evil enemy, and they think it's estradiol. So we just have to stop this. That's why, that estradiol is a woman's best friend. That's why I've changed it from being called a sex hormone to a life hormone. It's about life itself, about the functionality of every organ system, and key to every organ system functioning properly is a properly regulated immune system.
No, so beautifully stated. And I think there are probably listeners that are wondering if they are in menopause. Is there a magic window? Because I've heard 5 years, 5 years is the magic window. 5 years into menopause, if you start taking hormone replacement therapy, there'll be more benefits conferred. I've heard as far into menopause as 10 years for prevention and support against coronary artery disease. If we're speaking about generalities, again, not giving medical advice, for you, if you are starting to work with someone who's already in menopause and they're within that 5-year window or that 10-year window, what are the conversations that you're having with them? Because I think for so many of us, there was this, long period for most women where they were thinking, and many clinicians as well, that hormones are going to give people cancer. And that's not the message. We know that's actually not correct, but helping people understand to be thinking about these things as you're in perimenopause. But if you are already in menopause, what are some of the conversations that you have with your, patients?
Well, certainly early is better than late when it comes to starting, because it's much better in everything, right, to be preventative than to try to be reactive. So early is better, but I say it's never too late. Now, what do I base that on? Well, the whole thing about, which is now the general trend in the conventional medical world, is that hormones should be stopped arbitrarily at age 60, because once you're over 60, 59, okay, but 60, no way, okay? Once you hit 60, you're too old to be in hormones because suddenly they become dangerous. Although what the heck that mechanism would be, nobody, cares to elaborate upon. And if you're out 10 or more years from the onset of your last period, okay, from the last period. And that's another arbitrary thing anyway, right? But so if it's 10 or more years, it's too late for you, you've missed that window of opportunity, which is the words that they use. So first of all of that is based on the Women's Health Initiative, which to me is irrelevant to everything except to itself. It means, okay, if you use those products, that's what the advice you should follow, but I never use them. So that's not the advice I would give. Now, how do I know, or what do I base that it's never too late? Well, it turns out that all of the organizations like the North American Menopause Society, they're huge now in advocating for vaginal estrogen. Oh my gosh, they changed the name from vaginal atrophy to genitourinary syndrome of the menopause. Okay, because by the way, there are some committees, their whole job is to change the names of things, you know. So it's like so important, you know. So that's big focus now, is genitourinary syndrome of the menopause, for better urological health, for better vaginal health. And they'll give vaginal estrogen, estradiol. Occasionally they'll give vaginal Premarin, but usually estradiol, and they will give it at any age. It doesn't matter if a woman is 20, 30 years out in menopause. There's no maximum time, you know, that you've crossed the line, you're too late. No, there is never a too late. Now, guess what happens when you give the vagina estrogen? It gets better. Does it turn like a 70-year-old vagina into a 19-year-old vagina? No, but it gets healthier. There's no question it gets healthier, right? So why would I think that only vaginal estrogen receptors can wake up? That doesn't make any logical sense whatsoever. There's nothing that evolved unique for the vagina that only the vagina can actually benefit, no matter how long it's been. So here's my thing. When you don't use receptors for a long time, they do become sort of like the equivalent of rusty. They may never become the same. You know, so I'm not going to say it'll be the same. That's why you don't want to have a gap when you don't have estrogen, you know, the proper estrogen, you know, in those receptors, because, you know, and you don't want them filled with endocrine disruptors either. They stretch them out of shape, so to speak, you know, so you always want to have estrogen, the estradiol in the receptors doing their job. But say you don't. Well, the receptors may never be quite optimal, but that doesn't mean they're useless, because the vagina has proven that. Now, what else has proven that? Especially back in the 1990s, but it's coming back again now. They did quite a lot of studies applying estradiol cream to skin. And what did they find? In women who were out in menopause a long, long time, if they put it on the skin, in just 2 weeks, there was a reduction in visible wrinkles. 2 weeks. And you could see reduced wrinkling of the skin. Of course, the skin has estrogen receptors throughout every single layer. Every single part of skin has estrogen receptors. So if the skin and the vagina, of course, the vagina is like a type of skin, but if skin, no matter where it is on the body, can actually benefit, why would I think that arteries can't, or the brain can't, or, you know, that your bones can? In fact, we know from the Women's Health Initiative that giving the Premarin, that the bones benefited, and also the gut benefited. So come on, of course, it's not going to be the same. It's not going to be as good as if you were on, you know, full proper replacement therapy and supplemental therapy from the very beginning of perimenopause, but it's still good. And, you know, good is better than bad. So let's go for it. So now, the whole risk, all of the risks that they said don't give it to older women, comes from this excessive clotting propensity of the conjugated equine estrogens. I mentioned it increases the risk of blood clotting 4-fold. Well, if you take an older woman who already has vascular disease, and then you put in a product that increases blood clotting, she may end up having, you know, ruptured plaque, and then she may have problems with vascular flow. And they could be like like little micro vessels. So then she increases her risk of vascular dementia, which is what they saw, you know, and increases risk of hypertension, coronary artery disease, can lead to heart attacks and strokes and so on. So what did they see in the Women's Health Initiative? Well, they saw an increase in dementia in much older women, and probably it's due to vascular dementia because of the alteration in the blood clotting factors from the conjugated equine estrogen, and there was an increase in stroke. Well, that's a blood clotting problem. They actually didn't end up finding that there was an increase in heart attacks, surprisingly, you know, and they did have an increase in DVTs, like you said, deep vein thrombosis. So it's all about the clotting problem. That only applies to that product. It doesn't apply to real estrogen, that's estradiol, that, you know, is exactly a clone of what's made by the ovary. Now, it's really important to understand blood clotting is part of the inflammatory response. And it's life-saving, because remember, inflammation is triggered by trauma, damage, or by pathogens. And If you have trauma, you want to have blood clotting so you don't bleed to death if you have a laceration, right? That can be life-saving. And the clotting mechanism is the same mechanism that creates walling off an abscess cavity. So that's part of survival from an infection as well. Like oh my gosh, that story about your ruptured appendix. Well, in ancient times, some people actually survived a ruptured appendix without surgery because their immune system walled it off. That's
actually what happened, during that 13-day hospitalization. And my surgeon sent me home, and then they did surgery 6 weeks later. But when she went in to remove it laparoscopically, she took all these photos, and she said, Cynthia, there's no question in my mind that this is what saved your life, was that your body walled this off. But at some point in the future, there would have been a recurrent issue. So to your point, before people had the ability to intervene and remove appendixes when they were inflamed and sick, there were those of us that, by virtue of probably a healthy, robust immune response, were able to wall the infection off. But how important that is to understand that distinction of that inflammatory response when it's working optimally.
And that required estradiol for that to work. That's why older people will often have no response, from a symptom point of view, if they have a ruptured appendix, because they don't actually have the proper immune response, and then they just die. So and look at the whole experience with COVID. Who tended to die? The older people, obviously. And also there's even published data. I said this from the get-go. As soon as COVID came out as, a pandemic, it's like, we should do a study. Women with estrogen are going to do better. Well, I couldn't get anyone interested in doing that study with me.
Really?
Others did it, and it showed women who are properly provided with systemic estradiol in their bodies, they did better. Like, big surprise to me. Of course not, because the immune system works better in every aspect, including, of course, fighting off pathogens when you have that proper amount. And, a lot of the problem that happened with COVID was people went into what they called like a cytokine storm. And that's the case when you don't have the proper hormones. And, estrogen, is made in men as well, right? Because we said that it comes from testosterone. So older men tend to have low testosterone, right? So what you have is the proper on and off switch. So those people could turn on inflammation in a chaotic sort of way, but they couldn't turn it off. You need estradiol to turn off the inflammation response too, which is what's not happening in postmenopausal women. So, you can thank your estradiol for saving your life.
Well, great. You want to know what's interesting is that I never had a period again after that, but I lost 15 pounds, and kind of the working hypothesis was because I lost so much weight, not being able to eat for 13 days, that stress probably pushed me over the edge. I know that average age of menopause in the United States is 51, as all of us know. But in my late 40s, getting that sick and being hospitalized, I think that kind of just shoved me. Maybe I would have had a couple more years before I went into menopause, but that kind of pushed me off the cliff.
Wow. Well, that's quite a story in itself, but I'm sure glad it had such a happy ending.
Yes, absolutely. Well, I could talk to you for hours. I'm hopeful I can persuade you to come back for a fourth podcast so we can talk about brain and bone health, because these are, again, very important topics for women. Please let my listeners know how to connect with you, how to get your books. I always say that, your resources and, your messaging is so vital and so needed in a space where there's sometimes a lot of polarity. You're always a kind of bright, shining light of, advocacy for women. And for that, I'm very grateful.
Well, I appreciate it because, sometimes it is an uphill battle. That is true. So I have an old-fashioned brick and mortar medical practice in Irvine, that's Southern California, where I see patients every day, and I will be seeing them shortly. And so it's called the Integrative Medical Group of Irvine. And I do have 3 books out so far. And in terms of menopause, the most recent one is called Menopause, 50 Things You Need to Know. And then I have 2 books in the PCOS SOS series for women who suffer from polycystic ovary syndrome, which is a very high percentage of women these days. So, and those are easily obtainable on Amazon.
Well, thank you again, Dr. Gersh. Always a pleasure. Hey, if you like this video, you guys are going to love this video, and I'll see you there.
conversation I'd love to have with every 35-year-old woman is that once 40 hits, your ovaries are gonna be done. And they're gonna slowly, it's not like it's done overnight, they're gonna slowly decline. It's gonna take 10 to 15 years for these ovaries to be out. But you literally have an organ that is done doing its job. It'd be like if your heart was like, hey, I'm done. I'm just going to slowly like this. I don't understand why we don't talk about this.
Right.